all can hear me. If those I can see can raise a hand. Most of you on the as attendees are not being able to raise your hand, but I think you might be able to put something in the chat or raise your hand. Okay, I'm seeing hands raised. Okay, well, let's get started. I'm David Byrd. I'm a surgical oncologist at SCCA and the University of Washington. And I've had the pleasure and honor of hosting our Northwest Melanoma Symposium. We initially called it Science to Survivorship since its beginning in 2006. So this is the 14th year of this. The reason I can remember the date is my co-chair in 2006 was then 16-year-old Katie Bunker, who was a melanoma survivor from age 13. And age 16, she co-chaired this first event with me and basically took down the audience at age 16. I felt sorry for anyone that needed to come after Katie in that whole session, but that set the stage for what was the start of a great series. And as you know, this is a very odd year in many ways. COVID has changed lives throughout the world. We all know that cancer and COVID did not speak to each other. Cancer has gone on full speed along with COVID, but COVID has changed many of the ways that we have done things and certainly the way we present things. I'm sure I speak on behalf of Evan and myself in saying we really hope this next symposium will be an in-person symposium. I suspect that many people in this symposium have been the regular attendees. Some of you have come, I think, all of these 14 years, and I cannot thank you enough. I'm just so sorry I cannot see you today, but thank you for being there. For those of you who are new to this, welcome. I just want to give some quick background. This has gone on for 14 years. This has been a wonderful relationship with the Melanoma Research Foundation, and you'll hear from Amy Marbaugh in just a moment, the entire time where they have co-sponsored this event along with Seattle Cancer Care Alliance and really helped us be quite successful and continue to make this a free, open event, primarily geared toward patients and families, but all professionals and others are welcome to join. And we've had a wealth of speakers who've come to join this. In years past, we have had the last part of the symposium be patient stories. And I know we don't have that today. This is an abbreviated session because we wanted to get back online going, but I'm sure Evan is hoping that we can get back to patient stories, hopefully as soon as next year. I'm mentioning that because many of you on this session have stories, and please volunteer if you're comfortable being willing to share your stories next year. No story is too small. All stories move the room more than any of the speakers move the room. So that's just sort of an advertisement for next year. The other thing that's really important to me, this is one of the most important things that in terms of meaning to me, it's the most rewarding speaking event that I've ever been part of. And I cannot tell you what an honor and pleasure it's been to host this. However, I can also tell you that Evan Hall has jumped in over a year ago and basically said, this is wonderful. This is fascinating. I love being part of this. And I said, let's talk. And it's quite clear to me that succession planning is happening. And I'm delighted to announce that Evan will be taking over the main ownership of getting this going. He's going to want partners as well. And I'll certainly be in the picture. I'm not going anywhere, by the way. But this will be Evan Hall's symposium. And Vitu Shrian from SCCA has been a remarkable help in setting this up. So I really want to give Vitu credit for this. I know you've all heard from her. But I just wanted to say some of these comments up front to say this is a commitment by our organization to bring this to patients and families. There's no other patient-centered event for melanoma patients in the Northwest. And what a pleasure it's been to do this. So I'm going to hand this over to Dr. Evan Hall, assistant professor at University of Washington. He's also he's a medical oncologist. He takes care of melanoma patients. He's also part of the clinical research division at the Fred Hutch. And Evan, I'm going to pass a virtual baton over to you. Thank you so much.
Well, thanks, David, for those very kind words. It's really an honor and a privilege to be able to participate and help organize this event this year. I think the next part of before we get to our agenda, I'd like to invite Amy Marbaugh from the Melanoma Research Foundation to say a few words.
Great. Thank you, Dr. Hall. Thank you, Dr. Byrd. We are very excited at the MRF to be here today. And now I'm going to attempt to share my screen. I think we all will be holding our collective breaths as each of the presenters goes to share their screens today. So I'm the first one to switch. And so hopefully everyone can see my screen. Whew, all right, we made it. First one down. Off to a good start. Hi, everyone. My name is Amy Marbaugh. I am the Education Officer at the Melanoma Research Foundation. I am new to the Melanoma Research Foundation. This is month 3 for me. I started in January. However, I am not new to oncology. I've been an oncology nurse for the past 10 plus years in direct patient care before moving over to the nonprofit cancer space and being able to work with patients and caregivers and providers and cancer centers across the country has been a really big benefit to my career and to me personally. And I'm just really happy to be here today. The MRF is located in Washington, D.C., but we have reaches all across the U.S. and in some cases around the world as well with some of our other initiatives. So I just wanted to do a brief background about the MRF. Many of you, if you've been to these symposia events in the past, you probably are very familiar with the MRF, but in case you are new, we are very happy you have found us, and we are happy to provide a little bit of background today. So the Melanoma Research Foundation was founded in 1996, so 25 years ago, by a melanoma patient named Diana Ashby. She created the MRF after battling melanoma for 3 years, and she became increasingly frustrated with medical treatments and research for melanoma. And so to honor her legacy, the MRF has a 3-pillar mission statement where we focus on research, education, and advocacy. So our big push is with medical research, accelerating medical research to find life-saving advances. You can see that we've had a pretty broad reach since 1998 when funding projects across the U.S., research grants for researchers, for providers, throughout their careers. We have the MRF Breakthrough Consortium, a group of cancer centers across the country who come together to discuss the latest and greatest in melanoma research. We have an emphasis on rare subtypes, which include ocular melanoma, mucosal, as well as pediatrics. And we are starting a push into the brain metastases that melanoma can cause. So a lot of research going into our efforts. We also educate patients, caregivers, and the public about prevention, diagnosis, and treatment. So we do that in a variety of ways. So obviously through these patient symposia, so when they're in person or virtual as they are today, through several forms of online education, printed material, webinars, animated videos, as well as a patient and caregiver online forum. And if people have questions about any of our resources today, please enter that in the chat. My colleague Leanna and I are happy to point you in the right direction on our website where you can find additional information. And lastly, we serve as an advocate for the entire melanoma community. So working at the federal and state level, creating an advocacy toolkit for individuals to use in their own community, as well as having our annual advocacy days where we provide access to your US representative and your US senators to really lobby for melanoma awareness throughout the federal level. As I mentioned before, this is our 25th anniversary. It's an exciting time at the MRF. We have a lot of exciting initiatives and events coming this year. So we hope that you will stay tuned, check out our website frequently for all the updates. But we are very excited that this is our 25th year, as well as the continuing our partnership and with Seattle Cancer Care Alliance. I just want to do a quick thank you to our sponsors who help support our patient symposia series, Bristol Myers Squibb, Merck, Alchemies, and Oncosec. They allow us to continue to do our work, and we're grateful for their we're appreciative of their support. So I'm going to leave this slide up for a second, just so you can write down our email address, or you can find us on Facebook, Twitter, or Instagram. we're just, again, very happy to be a partner with Seattle Cancer Care Alliance to help co-sponsor this event. We will see you in person next year. I am very certain of that. Look forward to coming to Seattle to see all of you. And hopefully we can also have a virtual component perhaps to continue to do that reach if you're unable to come to the Seattle area. So with that, I'm going to turn it over back to Dr. Hall, and we'll get started with today's event.
Great. Well, thank you, Amy, for that lovely introduction. Can everyone hear me okay? I heard my audio might have been a little low on the last time. It's better? David, more volume? Okay, let me change my microphone.
Is this better?
Yes.
Okay, thank you.
Thank you.
This is a look at our agenda for today. We have 3 different sections of speakers and talks. So starting off is going to be supportive care or things that really patients have more control over and are more in the patient domain, things like exercise and diet. And we're really excited to have Dr. Betof Warner join us from Memorial Sloan Kettering as our keynote speaker today, and Ray Palko, one of our dietitians at the Seattle Cancer Care Alliance. Then after a brief break, we will move on to talking about the treatment of localized disease. And we have a really interesting presentation from Dr. Moshiri, one of our dermatologists and dermatopathologists, about how pathologists and dermatologists approach melanoma. Dr. Kim, one of our surgical oncologists, will speak about surgical considerations and also looking towards the future of how surgery may be changing for melanoma patients. And then after a second break, we will move on to systemic therapies or treatments or considerations for more advanced disease. And I'll be speaking along with Dr. Bhatia, one of my colleagues in the medical oncology group here at the Seattle Cancer Care Alliance. So that's an overview of where we are. Just a few notes. The webinar will be recorded. If you have questions for the speakers, we are definitely going to have time, at least 5 or so minutes after each talk to do questions. So please write them in the chat function, and then myself and Dr. Byrd will look through and ask those to the speakers during that time. And if you're accidentally logged out of the webinar, if you just go back to the original link that got you here, you should be able to re-enter the webinar during the sessions. So I'm very excited to introduce our first speaker. Dr. Betof Warner is a rising star in melanoma medical oncology and also a friend in the melanoma space. So it's really exciting to get to introduce her. She did her medical degree and PhD in cancer biology at Duke University, and then did her internal medicine residency at Massachusetts General Hospital in Boston, followed by her fellowship at Memorial Sloan Kettering, where she became increasingly influential in the field of melanoma. She's been on the faculty at MSK since 2019. She's won many awards, including a very prestigious ASCO Young Investigator Award on her work of the impact of exercise on the immune system and cancer, which is what she's going to be talking to us today about. Dr. Betof Warner, thank you so much for joining us.
It is my pleasure. Thank you so much for having me. Let me see if I can be number 2 to successfully share my screen. Let's see. All right, can you all see that? Fantastic. So Dr. Hall, thank you so much for the kind introduction. All of you, thank you for having me. I sincerely wish that I could be there in person with you, and hope that in a future year I can join you in Seattle for what is looking to be a really wonderful event. I'm also thankful for letting me go first so that I don't have to be the person following in Katie's footsteps as in previous years. But I'm delighted to be with you today to talk about my work on exercise and melanoma care, and truly to hopefully introduce some of you to what may be a new concept to you, that movement truly is medicine. So if we take a step back and look at the history here, this is a new field. It's a new field that we tend to call exercise oncology, which some of you may never have actually heard of. And that includes some of the clinicians in the group here may not have actually heard of this field. And this really started back in the 1980s with this doctoral dissertation. That was a study looking at whether patients with stage 2 breast cancer undergoing adjuvant chemotherapy would benefit either psychologically or physiologically from supervised aerobic exercise when compared to patients who were just told to do their normal activities. And this project involved interval training on a bike for about 20 to 30 minutes per day, 3 times weekly. It was a 10-week intervention. And really, they just used a target of getting patients and their participants' heart rates to 60 to 85% of the heart rate max. And what they found was, first and foremost, that participants actually completed the program. And that was not clear before this, right? If we talk to participants on chemotherapy, particularly for breast cancer, which can be a very aggressive chemotherapy regimen, people thought we were nuts and still continue to think we are nuts when we talk to them about doing exercise during their treatment. So this was a really powerful piece of work that showed that, in fact, patients and participants in these trials can complete a training program. The patients who did participate were able to work harder and longer than controls, and they improved their fitness by about 40% compared to even a pre-training value, which was for most patients prior to actually starting chemotherapy. So these patients were actually able to improve their fitness from where they were even before starting their therapy. And the field just blew up from here. So this is a look at just PubMed citations. So for those of you who are patients or caregivers in the audience, this is where we get most of our scientific references from. And this is just a search of PubMed that looks at how many papers have been published starting in the 1990s for the field of exercise oncology. And the numbers here don't necessarily matter all that much, but what you can see is this beautiful exponential growth. And I need to update this slide because it has continued to exponentially grow through 2020 and now 2021. And what you can see are a few milestones here. So in 2009, 2010, right at the beginning of 2010, the first roundtable recommendations from the American College of Sports Medicine came out, recommending an exercise regimen for patients either on treatment or post-treatment for cancer. And this was certainly not specific to melanoma. And to be honest, melanoma wasn't really one of the considerations at that time. But this has grown tremendously. And just last year, new roundtable recommendations have come out that are an update of those previous recommendations. And those were actually the first recommendations in the world of exercise guidelines for patients with cancer. And that says something to you, right? If the first guidelines came out in this field in 2010, right? We are learning every day. We are refining what we do every day. And I've been really delighted. I've been a part of this field since 2005. And so I've really gotten to witness the growth and the growing interest in using exercise as an adjuvant cancer therapy. So first and foremost, I want to talk about the benefits of exercise for patients with cancer in terms of symptom management. And this is where there's absolutely no question that exercise is beneficial. There are data up, down, backwards, and forwards. And I feel very, very confident recommending exercise to all patients with cancer with a few considerations based on these data. So this citation here is from that first roundtable discussion, as I mentioned, that came out in 2010, that was led by Katie Schmitz, who's a full professor at the University of Penn State University, Hershey now, but who has really been a true pioneer in this field. And the conclusions from this group were that exercise is safe during treatment, and that was also not completely clear. Right? We think about patients with brain metastases, and I'm happy to answer some questions on that. We think about patients with bone metastases. And some of these questions have really been key to our field. But really this work and body of work concluded that exercise is safe during and after treatment. And several meta-analyses have shown that exercise can improve aerobic fitness, quality of life, health-related quality of life on specific validated assays, fatigue, anxiety, and self-esteem. And another key consideration for some of our patients particularly is that resistance training also can be safely performed in patients. This was studied first in breast cancer, but those patients at risk for and those who have lymphedema. And as many of you in the audience know, this can be a large consideration for many of our melanoma patients who undergo, axillary node dissections or groin node dissections. And prior to this, just as we told many patients don't get a blood draw on that side, almost all of these patients were told they should not exercise, they should not use that arm, they should minimize any use of that arm or leg to try to prevent complications. So this was really seminal work. And since that time, as I showed you in that growing number of publications, we've seen survival benefits of exercise for patients with cancer. So what you're looking at here is just a chart that I have compiled from a variety of different studies, but looking at pre-diagnosis physical activity versus post-diagnosis physical activity. And I distinguish physical activity from exercise a little bit because exercise is deliberate training, whereas physical activity can be things like, that parking in the back of the parking lot and walking to the grocery store a little bit further. And I can talk a little more about that as we go. But if we look in much more well-established cancers, things like breast cancer or colorectal cancer, we know that pre-diagnosis and post-diagnosis physical activity lead to decreases in cancer-specific and all-cause mortality. In lung cancer, this field is emerging. It was a little bit late to the game. In patients with lung cancer, we were very nervous to exercise, particularly patients who were on oxygen. We've since shown that that is safe and effective. But in melanoma, this is a big black hole, or in this case, an orange hole. We really have very little information about what the effects of physical activity are. We do know that this very powerful paper came out in JAMA Internal Medicine in 2016 that showed an association of physical activity with the risk of developing a cancer in about 1.5 million adults. Now, this is different than using exercise after a cancer diagnosis. So we're talking about prevention here. And I will say, this was terrifying to me. If we look down here at the bottom, our melanoma patients actually showed that exercise may increase the risk of developing melanoma. And many of us in this field started panicking and looking at mechanism and why this may be. And several of us took a step back and asked the organizers of this study, did you control for outdoor activity? And did you control for sun exposure? And in fact, they did not. And so this very powerful paper that scared some people, including physicians, away from recommending exercise, particularly in our field, was in fact confounded by this very powerful factor that we all know, which is the sun. So when we add sunscreen and appropriate sun protection, including SPF clothing, indoor activity, all of those usual types of things that you've all heard your physicians talk about, we actually have no idea what the effects of physical activity on melanoma development or progression are. But I think this is important, as this paper received a lot of attention. It was highlighted in the New York Times and many other popular press sources. And I think it's really important that we understand how that applies to our melanoma patients. So this is where I come in. So I have done a tremendous amount of work over the years now on trying to understand how exercise actually may affect a tumor. Not just looking at the epidemiologic outcomes or understanding whether patients who report exercise do better or do worse, but in fact, trying to get down to the nitty-gritty of what are the mechanisms here? How does exercise affect a tumor and a system to promote or suppress tumor growth? So this is from a review we published in 2016, but many of these are still unknown pathways. So some key mediators of exercise response, if we just break this down to a mouse running on a wheel, we know are things like muscle, the bone marrow with cellular movements from the bone marrow into the blood, the fat, and other organs like the liver, which is key in glucose control, and many other things. This has key impacts on a variety of what I'll call host pathways. And I say host here because in patients, we're talking about people. I spend a lot of my time studying this in mice. So I will talk about these sort of more in general, but we know that metabolism plays a key role here. Oxidative stress, so things like reactive oxygen species, or many of you have heard about antioxidants or nitric oxide. Immune surveillance, and that's where I'll spend a lot of our time today. Sex hormones, things like estrogen and androgens, which we know play key roles in things like breast cancer or prostate cancer, but turns out likely also play important roles in melanoma. And we've seen that with some of the obesity data over the last couple of years. And then stress response, things like corticosteroids and catecholamine. And all of these pathways can have profound effects on the tumor itself and the tumor microenvironment. And by microenvironment, we mean everything else besides the tumor cells that make up a tumor. So the blood vessels that go to the tumor, the structures that support a growth of a tumor, all of these things actually influence the ability of our treatments to actually successfully control a tumor. And that's key things like angiogenesis, or blood vessel growth, cellular apoptosis, which is death of tumor cells, cell signaling, DNA synthesis and repair, metabolism, oxidative stress, which we talked about, and many other things. So this paper came out right as I was joining the melanoma world and was a fellow at this time at Memorial Sloan Kettering. And it was really the first mouse study of exercise in melanoma. And I will actually point out that this study, while it is reported as exercise, studies physical activity. So this is a mouse jumping on and off a wheel and running a little bit a day, right? And when a mouse gets tired, it jumps off the wheel. And when it feels like it, it jumps back on. And that's a perfect example of the difference between physical activity and exercise, right? Exercise, again, is deliberate training, whereas physical activity are your 10,000 steps per day, for example. But this paper did show, in fact, that physical activity leads to an increase in mobilization of NK cells, which are key immune cells that control tumor growth. And that's mediated by some factors like epinephrine, which is a stress response hormone, and IL-6, which is a key inflammatory mediator. And they showed that, in fact, with this physical activity, you can see the control on the left, the exercise in gray on the right, that the size of the tumors in these mice were smaller. Now, many of you are going to look at me and say, that's great. These are mice, not humans. And I am going to 100% completely agree with you. But one of the benefits of mice is that it takes out many other factors, things that we are going to hear about later today, like diet, stress, sleep, right? All of these things that we also know can have profound effects on patients. And when we're trying to understand mechanism here, it's actually important to go back to these simplistic models, which is why I call myself a glorified mouse personal trainer, and I run mice on treadmills all day. So this is when I'm not seeing patients, what I am, a cartoon of what I'm doing. So I give mice melanoma, unfortunately. And then I either put that mouse on a treadmill for a true model of exercise, or I have lazy sloth mice, as I like to call them, who are sitting back watching their friends run. And then I measure the immune response. Okay? And I measure that immune response systemically, and I measure that immune response in the tumor. And I'll show you just some simple data today of what we've seen thus far. So if I give a mouse melanoma and then I acclimate that mouse to a treadmill, and I do that to decrease the stress response. So you can imagine if you're a poor little mouse who's never seen a treadmill before, and I put you on a treadmill, it's going to be really scary. So we do a 7-day acclimation period to decrease that stress response, because we know that stress in both mice and humans can, in fact, feed tumor growth or lead to hormones that feed tumor growth. So we do this acclimation period, and then we watch tumor growth when we randomize mice to either running or sedentary. And if we look here at this graph, what you can see is the sedentary mice shown in light blue. Sorry that the labels aren't showing up for you, but the sedentary mice shown here in aqua have much faster tumor growth. So this is tumor volume on the left versus days along the x-axis. And these tumors grow much faster than your blue mice who exercise. And this has been repeated many, many times now and is in line with those physical activity data that I showed you on the slide before. But in fact, the effect is stronger with exercise. When I take the immune cells out of this system, so I use immune deficient mice, or what is known as RAG mice, and these immune deficient mice do not have B or T cells or B or T lymphocytes, this effect goes away. And that tells us sort of unequivocally that the immune system is playing an important mediating role here in the effect of exercise. It may not be the only mediator, but it is a key mediator. And this really led us to think of all of the ways that we could perhaps use exercise to make our other therapies work better, right? So not just thinking about exercise alone as a therapy, which some do focus on, but my work really focuses on combinatorial approaches of exercise based on these mechanisms. So I haven't gone into some of the complex work that I worked on during my PhD that showed that exercise decreases hypoxia or improves oxygen delivery in a tumor, improves the structure of blood vessels so we can get more therapy to the tumor, changes tumor metabolism, and I have shown you briefly here about changes in the immune system. But each of those mechanisms really has the potential to influence chemotherapy, which thankfully for many of our melanoma patients is less of an acute concern, though many melanoma patients will see chemotherapy at some point during their course. Radiation therapy, which many of you are all too familiar with, and certainly potential effects on immunotherapies, and that's really where most of my work focuses on now. And we have talked about briefly that paper that looked at the NK cell toxicity. I focused largely on T cell responses since we know that that's a key mediator of drugs like ipilimumab or Yervoy, pembrolizumab or Keytruda, and Opdivo or nivolumab that many of you either have seen or at least have heard quite a bit about in the melanoma world. So what does that actually mean for patients, right? So I've talked a lot about what we do in mice and how we study this in mice, but what does that mean for you or your loved ones that have melanoma? We're still really working on this, and this field is growing day by day. So this study is the first study, it's called the iMove study, of exercise in patients with melanoma on immunotherapy. So this is a 30-patient, what we call pilot study, meant to establish safety and what we call feasibility. So can we actually do this? Can patients do this? And can we as healthcare providers actually carry out such a study? So 30 patients with metastatic melanoma that were scheduled to start immunotherapy between May and September of 2019. And this study actually ended up carrying on a bit longer than that and has not yet been published due to some COVID limitations. But the study design essentially looked at a 12-week intervention of what we call semi-supervised exercise. So some of the exercise sessions were done at the hospital with an exercise physiologist specifically trained in working with cancer patients, and others were check-ins by telephone as patients were instructed or participants were instructed on how to do said exercise at home. They were stratified by whether or not people actually met the recommendations for cancer patients at baseline. So those recommendations, which some of you may never have actually heard before, are 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise. So that's 30 minutes per day, 5 days a week, or 15 minutes per day, 5 days a week of vigorous intensity exercise, 5 days a week. In addition to that, there are some organizations that additionally recommend 2 to 3 resistance exercise sessions per week. Now, these don't have to be separate, right? One can do aerobic and resistance exercise combined. And in fact, that's what was used in this study. And this study used 4 face-to-face sessions that were done on the same day as the immunotherapy infusions. So either 2 weeks, 3 weeks, or 4 weeks apart, depending on what the immunotherapy regimen was. And 4 telephone sessions, as we talked about. And then there was a face-to-face session at the end of the entire study to reassess fitness. And we're looking forward to those data, though I don't have them yet. There was a smartphone app for everyone to check in with their exercise every day, similar to Apple Health or any of the other ones that many of us use just at baseline. And this exercise modality included some moderate intensity aerobic exercise, so fast walking or light cycling, some resistance training with bands, and stretching. So nothing, we're not asking people to run a marathon here. So what do we know and what don't we know? So I hope that I've at least started to convince you that exercise has some effects on the tumor. And hopefully, I think that those are beneficial. But what do we need to know to begin to use this as a better therapy for you and your loved ones? So how much exercise is really needed? These recommendations are really based just on what people have told us, and honestly, what the cardiovascular recommendations have been over many years. So you'll hear these recommendations 30 minutes a day, 5 days a week. They sound exactly like what someone's primary care physician or cardiologist might tell them. And that's because they were taken from exactly the same guidelines. But do we know that that's optimal for cancer patients? We don't. How often should one exercise? Is that 5 days a week really the best recommendation? The intensity of exercise, is walking the same as running, is the same as weightlifting? We don't know. The type of exercise, again, getting into this idea of aerobic exercise versus resistance exercise versus someone like me who really enjoys doing CrossFit, which, you know, mixes all of those all into one big smorgasbord. The timing of that exercise, does doing exercise the day of an infusion of immunotherapy, does that matter for T cell response or activation of the immune response or cytokines? And then obviously working on understanding how to maximize the efficacy of combinations. And so all of these things are the questions that I'm trying to answer both in mice and in people in my lab and in my work. And hopefully over the coming years, I will have much more to share with you and more answers than questions. But I think right now, we still unfortunately have more questions than answers. So for those of you who are patients or caregivers in the audience, how do you learn more about this? Or if you are interested in this, how might you find an exercise program that's close to you? So if you go to this website, Exercise is Medicine, which is run by the American College of Sports Medicine, and started, in fact, by Katie Schmitz during her time as president of that organization, there is a registry of programs for patients with cancer. This is growing. We've been working hard on this, but I did some work to find what might be close to you, at least for those of you in the Seattle general area. There are actually several, and in fact, more than there are available in New York City, resources available to you. So there is a hospital or clinic-based resource run by Dr. David Zucker that is called the Cancer Exercise Service. And this is for patients with all different cancers, adults only, that are referred by an oncologist. And this is a program now actually that's been going on 15 plus years. Livestrong, many of you may have heard of. So they have a program through the YMCA nationwide, and in fact, at several YMCAs throughout the world, that is exercise programs designed for patients with cancer. Specifically, however, this is for survivors or post-treatment patients. The YMCA has not yet felt comfortable integrating this program for patients who are on active treatment. So for those of you who are years out from your treatment, this may be a really good option for you, and it's available at any number of YMCAs in this area, actually. The Cancer Survivorship Rehabilitation and Wellness Program that is located at several sites in Washington, all cancers, adolescents, adults, and older adults, including those on palliative treatments. This is supervised by an exercise physiologist. And the last one I will highlight is the Revital Cancer Rehabilitation Program that is actually quite pervasive in this area and serves many, many patients. This includes things like physical therapy, occupational and speech language therapy, but also exercise physiologists specifically trained in patients with cancer. This is our melanoma group at Memorial Sloan Kettering. I'm so sorry that I couldn't be there to join you in person today, but I hope this provides some friendly faces across the country for those of you who may at some point want to hear more about this. And with that, I am happy to answer any questions you may have.
Great. Well, thank you, Dr. Betof Warner, for a wonderful talk. To the audience, please feel free to submit questions to the chat. I am just taking a look. While you're working on those, I have a question. Maybe I can get started. I'm wondering, so many patients have fatigue when we see them in clinic from their treatment or just from their surgery and recovering from that. How do you approach it in your clinic? Kind of the idea of, I'm already tired, can I actually do this?
So this is one of the absolute most common questions I get asked. And we know that about 30% of patients on immunotherapy will have fatigue just from the immunotherapy itself. Certainly that number is even higher after surgery. So this is every day in my clinic. And I tell patients that I know they think I'm crazy, but that this has been studied many, many times actually, and exercise is more effective at combating cancer-related fatigue than any drug that has ever been studied against. So if we include medicines like Ritalin or some of the other stimulants that cancer patients are often given for cancer-related fatigue, in fact, in randomized studies, exercise has been shown to be more effective at combating cancer-related fatigue than some of these medications. And that's a really important distinction. Now, they don't always have to be done in isolation. And again, we're not talking necessarily about, going out. I'm not asking patients to run a marathon. 30 minutes of walking outside every day is really quite sufficient. And what I tell many of my patients is to give it a try for 2 or 3 weeks. Right? The first 2 or 3 days, they may feel more tired because this is a new thing if they haven't been doing it. But by week 2 or 3, I've made believers out of almost all of them.
Great. And it sounds like, I'm waiting for questions to come through in the chat. It looks like there's some people raising their hands. Just a reminder, if you can type it in the chat box, that's a way we can see what your question is and get it answered by Dr. Betof Warner. It sounds like starting slow is fine. There's not a need to immediately start jogging if it's not something you've done in the last 15 or 20 years. Taking a walk, planning for a walk every day or two and having that be a relatively short duration is at least a place to get started. Would you agree with that?
Absolutely. And in fact, I would not recommend somebody who hasn't exercised in 10 or 15 years facing a cancer diagnosis and all of the other things that go along with it to all of a sudden, start jogging 3 to 5 miles a day. That brings with it its own troubles. But if we can start integrating, 3 10-minute walks per day, right? That reaches that 30-minute threshold. So this does not even need to be 30 continuous minutes, right? Just getting your heart rate up for a total of 30 minutes per day. Or if you are someone really pressed for time, pushing that a little bit harder and even maybe speed walking, getting your heart rate up a little bit more for 15 minutes per day is really all that we're talking about.
Great. It looks like, I'm wondering, we have some hands raised, but I'm not seeing questions coming through the chat. I'm wondering if we're having a hard time. If anyone who's in the attendee audience would mind writing just a test message in the chat to see if we are able to collate those, that would be helpful. Looks like we got a hello from Dr. Bhatia. Do you have a question?
Yes, Dr. Warner, fascinating talk. Can you hear me okay?
You're breaking up a little bit,
Yeah.
unless it's me.
One second.
You sound a little bit like Darth Vader, Dr. Bhatia. I have to say, the audio is a little bit patchy.
Right, how about now?
Perfect.
Great. Yeah, these AirPods Pro are overrated, I think. So a fascinating talk. Thank you so much for joining us. My question is, probably outside of the cancer domain too. Like, should exercise be done with a goal in mind? Do we need to lose weight, or just getting your heart rate up is enough? And a lot of focus has been on what should be the optimal body weight, especially when it comes to responding to immunotherapy and all. So can you please comment on that?
I would love to. So this is a great question. I think that there are two different modalities or schools of thought when we think about exercise as an intervention, whether it's for cancer patients or beyond, right? And there are the benefits of exercise itself, right? So things like cardiovascular health, blood flow, shear stress, oxidative stress, metabolism. And then there are sort of the weight benefits of that, right? Where we get into caloric balance and should we be, trying to reduce weight and all of these things. And in some ways, these are slightly separate questions. So many of my colleagues, including, some that you will hear about today, have focused a lot, as you mentioned, on obesity, the obesity paradox, as we call it, which means that some patients who have obesity actually have improved responses to immunotherapy, as has been reported over the past several years. I personally have focused more on the physiologic effects of exercise itself. And that's part of why I have done a lot of this work in mice, to try to separate that. So I tend to keep mice weight neutral. And in fact, I'm trying to understand whether getting the heart rate itself up, right, without affecting weight, can have beneficial effects. And it seems to in and of itself, and it seems to lead to cellular mobilization through T cells and other things. I think that once we understand that better, we can combine that with our colleagues that are studying nutrition and weight management and trying to understand energetic balance to understand the interplay there. But right now, unfortunately, our understanding of mechanism of each of those separately is still in its nascency. And so I think it's very hard to understand them together if we can't yet understand, the interventions alone. That being said, one of the things that we do know, and I do a lot of work in cancer survivorship, particularly for adolescent and young adult patients, is that cancer survivors have long-term poor cardiovascular health, even independent of whether they got chemotherapy or immunotherapy, and that their exercise participation tends to be lower than their age-matched counterparts. And so even in a weight neutral situation, I think it's really important that we focus on just the pure cardiovascular benefits of these patients, because particularly our younger patients who are treated and maybe have complete responses to their melanoma at age 20 or 30, we don't want them to go on and die of cardiovascular disease at 50, right? And we know that their risk of doing that is actually much, much higher than their age-matched counterparts.
Great. Well, I think, so just as a reminder to the audience, the best way to submit a question is through the chat function, which is at the bottom of the screen. There's a little text bubble, if you will, and you can click on that and type a question. We've gotten a few that have come through, and I see there's also people who have raised their hand. So I'm going to ask a question from the audience here. It asks about the duration of how long you need to do the exercise. Is this something that is really best just done without an end date, or is this something that really should be focused during the time of cancer treatment and then maybe is less important afterwards?
That is a wonderful question. And the day I find the answer to that, I will be shouting it from the rooftops on Twitter and everywhere else. I will say that some of my work pre-melanoma, when I was working in breast cancer, where this field really started, looked at exercise before a cancer diagnosis versus after a cancer diagnosis versus continuous. And we showed that certainly the biological effects are different, but either actually leads to improved outcomes. And that's been reported in breast cancer. That has been reported in colorectal cancer and lung cancer as well. I can't say that I can confidently say that in melanoma yet, in a rare disease. It just hasn't been studied. I think that the effects are different, right? So when I think about exercise for patients that are currently undergoing treatment, whether that's surgery or radiation or immunotherapy or anything else, I think in fact about those quality of life benefits, the fatigue, the anxiety, and maybe these biologic benefits that we are starting to understand better in terms of immune activation. And post-treatment, right? Certainly that immune activation may continue to play an important role for patients who've had adjuvant therapy or even those who are complete responders. But we really don't know that yet. But where this really does come into play is this survivorship population, where we know that the long-term cardiovascular effects of cancer therapy, or even having had cancer at some point, really are detrimental to people's long-term health. And so while I would love to tell you I have data to say this, I'm an exercise person. I think people should exercise throughout their life, of course. But I think that the benefits are very different. And to Dr. Badia's point, the goals are very different. And therefore our recommendations of what those, goals and treatment modalities or exercise modalities should be, will likely be different as we understand the biology better.
Great. And I think, so let's see, it may have been, so Pitu, I think we're going to try to unmute one of the people who have raised their hand to see if they'd like to ask a question that way, if they're having a hard time using the chat function.
Yeah, so I'm going to unmute Deborah. Deborah, you can ask your question now.
You can hear me?
Yep.
Yes.
I just keep thinking about, I would like to swim, which is at the Y. I know with COVID at this time, it's probably not a good idea, but most of us, and it's due to treatment, we have a lower immune system. So is swimming okay or not recommended?
It's a really good question. I got asked this question 3 times in my clinic this week. I wish I had a better scientific answer for you. We know that swimming as an exercise modality is actually a very effective exercise modality for patients with cancer. And we have studied this, in the pre-COVID era, certainly. The transmission of COVID and concerns about indoor pools, I think, is certainly real right now. And I've, not based on great data, but just out of an abundance of caution, have been recommending my patients avoid indoor pools, during this time while we're still waiting for everyone to get vaccinated and, to really have as much control of COVID as we can. That being said, I think that with good social distancing, outdoor pools, certainly as it gets warmer there, would strongly encourage people to do with sunblock and SPF clothing. But I think that probably is a safe activity as long as you aren't right on top of everyone in the pool. And I would really encourage that, especially as it gets warmer and nicer outside. And I'm hoping that as we get into the fall and have better information about vaccination and the duration of vaccine effects, that could then switch over to more of an indoor pool throughout the colder months.
Great. Well, I think this was a wonderful talk. Thank you for kicking off our symposium as our keynote speaker. I want us to try to stay somewhat on schedule. We have but maybe if there's a way to collect any remaining questions by email, and then we could maybe see if we could get those answered after the event. That would be a good compromise.
Happy to do that. And also we can, if I can, I'm happy to share my Twitter handle. I realized it's not on here in the chat, and any of you can feel free to reach out to me by Twitter as well. It's probably the easiest way to get me.
Thank you. That's awesome. Great. So we are off and running. Wonderful talk. And we're going to move on to something that's very closely related to exercise, diet. So our next speaker is going to be Ray Palko. Ray is a registered dietitian at the Seattle Cancer Care Alliance. Actually, have known Ray for a while. He was also previously at Stanford, where I did my fellowship. Ray has special expertise in oncology nutrition. He's board certified in that. He sees patients regularly in our cancer center, including patients with melanoma. And he's going to talk to us about diet and the microbiome and the immune system.
All right. Thank you for that introduction, Dr. Hall. Now, okay, third one to see if I can get the screen sharing technology working. How are we looking? Is there a slide up there that everyone's seeing?
I'm seeing your screen. It's not in presenter mode, so I can see the thumbnails on the side.
Yeah, so let's see. From the beginning, how's that look?
That looks good.
All right, start my timer now. Yeah, again, thank you for that introduction, and thank you, Dr. Betof-Warner. Definitely activity and diet, they are the yin and yang, whether it's prevention, treatment, or survivorship, they really do play well together. They're both so important on their own, but when we can maximize both, even better. So for today's talk, I'm gonna center a little bit around the gut microbiome, but it's also gonna be a little bit intersectional and just kind of bouncing between the gut microbiome and evidence-based nutrition for lowering the risk of cancer in the first place. So first, to establish the microbiome, I'm gonna just read the definition for you all. A microbiome is a community of microorganisms such as bacteria, fungi, and viruses that inhabit a particular environment, and especially the collection of microorganisms living in or on the human body. So our microbiome, it inhabits nearly all sites of our body, including skin, mouth, vagina, gut. We will focus in primarily on this gut microbiome today. Our cells in our microbiome, many of you may have heard this, they outnumber our human cells. We have trillions of different microorganisms, coming from thousands of different species living inside our gut or GI tract. And there is a wide variability from person to person of the microbiome. And we often see it referred to in research as the last organ, thinking of the gut microbiome as a human organ, and it's really been researched a whole lot less than things like the heart and the lungs, the kidneys, etc. Why our microbiome is important to our health, there's a lot of different areas where we see this importance. Autoimmune diseases have been associated with dysfunction of the microbiome. Also, in terms of weight status, research has shown obesity influenced by the microbiome, with comparisons of twins showing weight discordant twins showing that the obese twin has a much less diverse microbiome than their lean twin. So diversity is going to be a big point here as the talk goes on. Currently, there are fecal microbiota transplantation is a technique that is being used to cure potentially fatal Clostridium difficile infections, to treat colitis, constipation, and IBS. We have also seen the use of fetal microbiota transplantation in research trying to, I'm jumping ahead to the next slide, I'll hold that. Multiple factors, including our diet, will influence our microbiome, and today's talk will focus in on how we can possibly make some changes in our diet to best support that microbiome. And important to note that there is no scientific consensus on what constitutes a healthy or optimum microbiome. This is really an area that is newer in research, and I imagine that we will be learning a lot more over the course of my remaining career. It would be interesting to see this talk in 20 years. So relating to immunotherapy, which is a common treatment modality for many of you, any of our patients on the call have probably had some experience with immunotherapy or may in the future. Research is exploring right now how the microbiome may enhance the effectiveness of the immunotherapy. This bullet here, one very specific interest point is the ability for our gut microbiota to overcome resistance to immune checkpoint inhibitors or ICIs, drugs like ipilimumab and nivolumab that, again, I can imagine there's a few people listening right now that have had experience with those drugs. My next bullet here, I want to redact and change my language a little bit. I want to strike out that word theory that didn't really belong there. So let's just say first, just a thought process here. If we have a better or a stronger gut microbiome, we will thereby have a stronger immune system. and receive a better effect from the immunotherapy. My slides did not get updated. I promise you, I was reading research up until the last minute yesterday. After my clinic patients all finished up, I came across some very interesting studies that I think are fair to take this out of the theoretical framework. Some of them were with mice, and we saw fecal microbiota transplantation in mice that was allowed to provide these mice with a stronger microbiome and a stronger response to the immune system. We've also seen some studies. There was one about 283 patients with a variety of different cancer types that received immune checkpoint inhibitors, and comparison was done to see which ones had taken antibiotics near and around the infusion of the immune checkpoint inhibitors. Now, when we take antibiotics, one thing we know about those is that they can kind of wipe out our gut microbiome temporarily. And these patients receiving the antibiotics in a close window around their infusion had poorer response to treatment. So I really think it's a safe space that we can go ahead and say, that this is likely having a benefit if we've got a stronger microbiome. And we really do want to try to encourage everyone on the active treatments, pending what type of GI side effects of other treatments you may have, to eat in a manner that will really support your microbiome. All right, so how do we do that? How do we support our gut microbiome via diet? Fiber is the main key. So there's a lot of very interesting pieces in the research that show that it's not just the nutrient of fiber that can help to support our microbiome, but the consistent thing that we see often across the board is any other type of nutrients, polyphenols that are found in grapes and red wine, other different substances that may help to support the microbiome. They all come along with fiber-rich plant-based foods. So I think for simplicity's sake, rather than at our dinner table trying to really think about combining X number of specific items and really targeting a set menu to increase our microbiome, let's just center in on fiber. Dietary fiber is the indigestible portion of plants. So all plant foods will have some degree of fiber. The more whole the plant food or less processed, the more fiber. So if we're focusing in on these plant foods, we'll get that fiber that is not digested by our human cells, but possibly by our microbiome. Dietary fiber, we have long recognized that has beneficial effects on digestion and cardiovascular health. And more recent research attention is shifting towards looking at fiber as a component of cancer risk reduction and the beneficial effects on the gut microbiome and or the immune system. I want to quickly just call out and mention two terms that probably have been heard by most of us in this arena: prebiotics and probiotics. So probiotics, these are live microorganisms intended to have a health benefit when consumed or applied to the body. So you can think of, it's the same type of bacteria that is making up our gut microbiome. So probiotics, there are some probiotic-rich foods, cultured or fermented things like yogurts, kefir, kimchi, and sauerkraut. And probiotic supplementation is a very popular thing that I won't delve into too heavily on this talk, but I think it's something that we don't want to be willy-nilly just popping probiotic supplements. We want to think of them as medicine and be sure we have targeted and appropriate reasons for taking them. Now, prebiotics, this is the much more kind of the bigger piece for most of us on a day-to-day supporting our gut microbiome. We've got those good cells in there. They're a living thing, so we need to feed them too. Prebiotics are non-digestible food ingredients that promote the growth of beneficial organisms in the intestines. Prebiotics, all prebiotics, I think we could safely say all prebiotics are fiber. Not necessarily all fiber is prebiotic, but I suspect that almost all of it is. Considering how much fiber we need, this is just a quick table I plucked of the adequate intake of fiber for men and women. Most of us here on the call, I imagine, are anywhere in the, well, we might have some in the 19 range. So you can see that our fiber requirements or adequate intake is a little bit higher, younger we are, and will lower down a little bit as we age. But also a lot of different research is showing or using higher fiber thresholds as part of the research question, or showing benefit that higher intakes, maybe up to 50 grams a day, could be beneficial. Again, I spoke earlier about not like counting things too closely or micromanaging your menu as you're putting your food together. I am not a big believer or fan in strictly tracking our nutrient intake. Now, if you are in a space right now with a low fiber diet, maybe you eat a lot of prepared or fast foods, don't eat a lot of whole plant foods, maybe you're very heavy on meat products. It can be a great little experiment for a few weeks' time just to track your intake of fiber, to understand where your baseline is and to try to raise up. But I think in a practical sense, it's much more about looking at our diet patterns. And we're even seeing, especially around the area of gastrointestinal health, microbiome, research is shifting away from looking at X grams of fiber or isolated specific food and more looking at the diet pattern overall. Because it's not just about what we ate in one meal. I do a lot of work in our prevention clinics, and one of the lines that I frequently will share with patients is say, it's not that if you eat a breakfast that's consistent with the risk reducing recommendations, you're not free of cancer risk until lunch, and then it resets, and then you have to do the same. Each time we eat a meal that is more plant-based and more high in fiber is just accelerating our benefit for our future health. So it really is about our overall diet patterns. And for this purpose, twofold, I'm encouraging all of my patients to really be following a more plant-based diet than the average American diet. When I say twofold, the next slide will look at this as it relates to cancer risks. Here in the context of our gut microbiome, a plant-based diet will support the amount of fiber that we need to come in and really feed our gut microbiome and keep all those good bugs happy. So this graphic here is taken from the AICR, which is American Institute for Cancer Research. This is really our worldwide expert body on synthesizing published research on nutrition and cancer and getting them into actionable guidelines that we can follow. So when I say plant-based diet, I am not aware yet of any uniformly accepted definition of a plant-based diet. Watching patient reactions when I tell them, we're looking for you to follow a plant-based diet, watching reactions is very interesting and fun. Oftentimes people may think that I'm advocating for veganism, eating only plant foods, or traditional vegetarianism. Some people think, oh, so I can only eat vegetables. You can eat meat, dairy, eggs, and animal products on a plant-based diet. When we're considering it plant-based for health purposes, for cancer risk reduction, our threshold is a 2-to-1 ratio. And you can see that here on this example of AICR's New American Plate. That's kind of the flagship graphic that they brought out to help illustrate this to people. It's a little small on the screen, but you can see there is a little wedge of chicken breast here. That's taken up about 1/3 of the plate. And then we have a nice variety of vegetables, broccoli, tomatoes, bell peppers, and summer squash, as well as brown rice, taking up 2/3 of the plate. So strive for a 2-to-1 plant to animal ratio, and that's hitting a plant-based diet. If we're even thinking about it down to the mealtime, every time the fork picks up a bite of meat, you want 2 bites of plants to go alongside. So you can see that a plant-based diet can fit a lot of different molds. This New American Plate, a flexitarian diet, which is people that choose all foods, but we're keeping the balance more on the plants. The lacto-ovo-vegetarian diet is the very traditional one, allowing eggs and dairy product, but no animal flesh. A Mediterranean diet, you hear cited in research for all types of health benefits. And really the hallmarks of the Mediterranean diet are whole, fresh plant foods, erring more towards seafood for any animal intake. A pescatarian diet would be very similar. It may look like lacto-ovo plus fish and seafood, or it may look like a vegan diet plus fish and seafood. And then a vegan diet is for those who choose only to consume plant products. Okay. And then as we look to this slide here, these are AICR's evidence-based guidelines on nutrition and cancer risk reduction. Definitely want to call out there the physical activity to Dr. Betof-Warner's presentation and my earlier comment about yin and yang. These play very nicely together. In terms of the diet-related recommendations, the frontline piece is here. Really, the frontline piece is eating a diet rich in whole grains, vegetables, fruits, and beans, really aiming to be on that plant-based diet. It's important, I think, that I call out here that all of the data that informs these recommendations cuts across multiple cancer types. Melanoma is not a part of any of the research that has informed this recommendation. I think that it's an area that definitely has less overall nutrition research and information. but it stands to reason that if this is helping to lower breast, prostate, lung, all these other cancers, let's follow these type of patterns to help lower our melanoma risk as well. Okay, and so what are some good prebiotic food sources? Our next slide will display where I think that basically any plant food, I'm going to call that a prebiotic and I'm going to encourage it. On this slide, coming from Monash University in Australia, which has an excellent gastroenterology program, they are highlighting by food groups some of the different highlight ones that we know for sure these have prebiotic effect. So in that vegetable area, one big thing I will point everyone to is this garlic, onion, leeks, shallot area. This is an easy way for all of your meals, you know, anytime you're preparing a vegetable. At my house, we roast a lot of vegetables pretty much all year long. That's our preferred method. If we're doing carrots or Brussels sprouts or whatever it is, we always put a quarter to a half of an onion on the roasting pan just for extra flavor, and it's getting us more prebiotics. It's a great option. Under legumes, what an excellent source for anyone trying to go more plant-based in our diet. The biggest fear I hear from a lot of people about going plant-based is, what about the protein? That's actually probably an unfounded fear, and protein malnutrition is extremely rare in people that are able to eat adequate calories for weight maintenance in this country. But if you were really worried about that protein, your legumes would be your excellent and rich source for your protein. I would also like to call out down here mentioning bread, cereals, and snacks. And when you see wheat bran and wheat, this is an area of unfortunate information about nutrition. There's been over the past, it's been at least a decade, the whole thought that wheat is so terrible and gluten is so terrible. Individuals with celiac disease must avoid gluten. Some people with digestive disorders or challenges get a little bit of irritation from gluten, but for many of us, wheat is such an excellent probiotic source, provided we're eating good sources of it, provided we're doing things like having bulgur wheat, which is cracked wheat kernels, or whole wheat sourdough bread, not eating a lot of Wonder Bread. So if we have the whole grain intact wheat, that really has a benefit. So to really expand out and think that all plant foods likely have some degree of probiotic effect, there's some fascinating research done called the American Gut Project. And there were over 11,000 samples sent in from citizen scientists. This was basically individuals logging their diet, what they ate, and sending stool samples. And those with the higher diversity in their diet, specifically people eating greater than 30 plant species in a week, as compared to those with lower diversity eating less than 10, had a way stronger microbiome. So that sounds like a whole lot here when you think 30 different plant species a week, but let's break it down by the day. And that's about like 4.45 per day, I think, which you can't eat 0.45 of a plant species. So let's round it up and think about, what if I had 5 different plant foods each day? To really balance out our diet, that might look like each day getting 2 different vegetables, 1 different fruit, 1 type of a whole grain, and 1 plant protein. So whether it's seed, a nut, or a legume. You know, so if you think about it that way on a daily basis, it's definitely achievable. When I first read this paper, I tracked my species for the week. It was a really fun exercise, and I was being very aggressive about it. And I think I got to about 40, but I was really proud of that. And so just starting to think about what are some of these foods that will fill it in. And this is, again, another one of these intersection pieces. I really want us thinking about the gut microbiome in this conversation, but again, all types of cancer risk. How are we going to lower this while we support our microbiome with whole plant foods? So from AICR, and this page, I should try to maybe in the chat, I'll put the link to this page in the chat after my talk, because they have an excellent page that really gives us good ideas about the plant foods we want to be eating. I tell all of my patients to take a look through this page, and I tell them that these are not the only cancer-fighting foods. These are just the ones that have been very heavily researched. So there's a couple more slides after this, and these are all just, again, excellent choices for prime nutrition overall. Looking at a few of these things, apples, to anyone locally, we really should eat an apple every day. There was a reason they told us that when we were growing up, and we live where the best apples are grown, so we definitely want to do those. Asparagus is coming into season in spring, so will be our blueberries, which is excellent. Next slide here, we see some really fun things that, like, coffee actually has cancer risk reduction property, provided that we're not loading with creams and sugars. So that's, you know, we get a lot of messaging, oh, you shouldn't have coffee. Maybe not. Flaxseed, definitely to try to get higher fiber intakes. If you're tracking and you're thinking, oh, I'm coming in around 20 grams a day, put a spoonful of ground flaxseed in your oatmeal in the morning, and that'll get you way closer to 30 grams. Garlic, again, that prebiotic effect that's in there, that's something that almost anything we cook, let's just throw some garlic cloves in. And of course, our pulses, which are dried beans, lentils, and legumes. Another great piece about this too is that if you eat animal protein 7 nights out of the week and you switch from one to doing beans and you track your grocery bill over the month, you're going to see some benefit there as well. And soy foods, I always like to call out, there's a lot of controversy around soy foods and cancer risk that is inaccurate. Soy foods do not fuel breast cancer or breast cancer risk. So any type of cancer risk or cancer history, feel comfortable with whole soy foods like edamame and tofu. And again, here calling out our whole grains. This is a spot that especially people, I'm an elder millennial, I'll be 41 this summer. People in my generation and age range are really digging into this. Ooh, grains are bad and I want to eat paleo. The spirit of the thought of a paleo diet is great, but there's not really good, strong science supporting it. Okay, I'm right at the 20-minute mark. I'm throwing up my final slide with some takeaways. Right, we've talked, okay, let's put the plants in the diet. Let's put the plants in the diet. Here's some great ways to do it. I've got you a list of 5 cookbooks here. That the top bullet, I promise you, I'm receiving no commission from the author. I do believe that every kitchen in our country needs this book, The Vegetable Butcher. It will really transform your ability to eat on a more plant-based way through your own cooking. So that's an excellent one. These are other good choices. And everyone should check out these websites as well. Cookforyourlife.org is maintained by our Dr. Greenlee, one of our naturopaths at Fred Hutch. Her lab maintains that site. And some of you who have been past patients may have met Kate Euland, one of my predecessor RDs here. She's shifted into academia, but she also moonlights with the Cook for Your Life website, keeping that up and running. And then AAICR has a great collection of recipes on their prevention site there. So, okay, let's transition over into questions whenever anyone is ready.
Awesome. Thank you, Ray, for a thorough presentation. I got lots of tips about, I think, what I could be doing better on my diet. One thing, you know, is actually there are a few questions. Here we go. So we'll ask these. These are better than my question anyway. So one question is there a difference between frozen or fresh vegetables? How do you think about that?
That is such a perfect question. There is not a whole lot of a difference. I will say actually the difference, so frozen vegetables, sometimes by the time they hit the plate, will be more nutrient dense than a fresh version. The reason for this, if we have broccoli growing out in the field, you know, it's not like we have frozen broccoli fields and fresh broccoli fields. The hardworking farm workers are just chopping these down and throwing them in bins. A portion may go direct to market to be sold fresh. Another portion may be flash frozen at within the day of being picked. So as a living thing, these plants, the second we remove them from the dirt and the water, they slowly start to lose their beneficial properties that aid our health. When frozen, there's no loss. Everything's trapped in. So you can imagine if it's frozen that day and stays frozen throughout, you know, a week or a month or 6 months before it hits our plate, the nutrition's locked in. Whereas when it's fresh and it's got a couple weeks from going from field to market to store to plate, we could slowly be losing some nutrition. So frozen produce is an excellent option and it's cheaper too. So it's an excellent option and totally a part of the cancer risk reduction diet or boosting your microbiome.
Great. The questions are rolling in, Ray. You've inspired the audience here. Many questions. So one question that came up, which relates to the question I had, is, you know, fiber, you know, can also kind of promote certain gastrointestinal symptoms in our patients, you know, bloating, you know, things like that. How do you think about people who might already be having gastrointestinal symptoms, either from their cancer, their treatment, or just from something they had before cancer, and increasing the fiber? How do you think about that?
Yeah, so we need to think about it on a very individualized approach, you know, down to that person thinking, okay, what is the specific issue? Do we have very frequent bloating, or do we have excessive gas, or are we experiencing diarrhea? You know, figuring out the specific issue. A lot of gastrointestinal problems that we experience, especially even ones as a result of cancer treatment, a lot of times fiber can actually be sort of a helpful and a modifying type of piece. So the old colloquial thought of a brat diet for diarrhea, that is trying to choose foods that are higher in soluble fiber. So there's two main camps of fiber. Insoluble does not dissolve in water. That's like skins and husks and peels. That adds bulk to our stool and can kind of speed up the transit time. Soluble fiber dissolves in water and creates a viscous gummy gel that in a patient experiencing diarrhea, that can actually be helpful in kind of binding things together. So if there is a GI issue, we want to look specifically, what is the issue itself? Is it related to the treatment? Is it something pre-existing? How might we modify fiber in that moment to try to help improve? And then if we can get back to a baseline, a great instance of this, so with Ipi and Nivo, ipilimumab and nivolumab, we get the issue with the colitis, right? That's that major side effect that can happen. And then sometimes it's even been where patients need to be on IV nutrition for a while the colon calms down. So in these cases, we'll modify the fiber for a little bit. We'll work on a blander, more easily digestible diet to get back to a point that we can tolerate a wider range. And then we try to bring back in that variety.
Great. Well, there's many questions in the chat. I would propose that we start our break now, but if Ray, if you or Dr. Betof Warner are able to stay on, I can continue to ask questions. We'll reconvene in, let's say at 10:30. I've eaten into our break because we've had such a great discussion. So we'll come back at 10:30 for Dr. Moshiri's talk. But if people are able to, for the next 5 minutes, we can just kind of continue the Q&A during the break time.
Sounds good.
So a question about the kind of fiber supplement. So if you're not getting it from your diet, there are different kinds of fiber on the market, Metamucil, things like that. Do you have a typical supplement for fiber that you recommend to patients?
Great question. And that's again going to hit an individualized piece and looking specifically, what are we trying to achieve? If we are thinking on that gut microbiome context, we would think definitely we want to try to transition to a point that whole food is really meeting things, but using a supplement as a bridge is smart. So soluble corn fiber as a supplement is one that we see has a prebiotic effect. Acacia fiber is another one that has a good prebiotic effect. Mentioning Metamucil there, Metamucil does not have a prebiotic effect, but it can still be very, very valuable. Metamucil, actually, I case studied my then partner, now husband, when I was in grad school. I case studied him on Metamucil to lower his cholesterol, and we shocked the doc, and we did not have to start statins. So Metamucil, very valuable, maybe in the diarrhea. It can lower cholesterol through that gummy viscous gel that we talked about. It traps circulating bile acids that turn into cholesterol and then expels them. So it definitely, we again want to take an individual specific approach on what do we want the extra fiber for to choose which supplement.
Great. Let's see. There was a question for Dr. Betof Warner from Leah. I'm trying to see if I can go back in the chat to see it. Let's see. While I'm doing that,
I'll quick throw out an answer on that mushroom question. So mushrooms, they probably should be a part of our food list in our diets. Mushrooms break the convention when I normally talk about food as coming from one of two origins, either plant or animal, but in truth, the fungi are their own kingdom. There's a lot of interest in research in fungi on anti-cancer benefits, and I think nutritionally they act pretty similar as a vegetable, and it would be a smart piece of the diet.
Great.
Leah, I just looked in the chat and I don't see your question. If you want to repost it, I'm more than happy to answer it.
Yeah, great. And then I think, Ray, if you wouldn't mind tackling a few of these many other questions that have been posed on diet in the chat, that would be great. While we kind of queue up, take a minute or two, and then we'll have Dr. Moshiri.
Sure thing. There's a great one here about preparing food with 100% whole grain flours with many fails, asking for advice. It can be a little bit challenging using 100% whole grain flours in a recipe that is written for refined grain flour. Also in the question, they said, what about doing half whole grain? I've had excellent success doing half whole grain flour in many of my recipes. One of my go-tos, I actually really like to use oat flour, and I'll do like half of the regular refined wheat and half with oat flour. And it is a benefit, right? Anything to take us to more fiber is good. So that's a great way to do it. I would encourage online research around cooking, whole grain cooking websites and cookbooks with recipes written specifically for whole grains. Sometimes we need to adjust the leavening ingredients a little bit, and I've only really taken the requisite amount of culinary courses to be a dietitian. I'm not a total expert there, but half whole grain is totally great, and look for some recipes specifically that way. Okay,
So Ray, I'm gonna we hit 10:30, so okay. I want us to try to stay somewhat on schedule if possible. If you wouldn't mind responding by text in the chat to specific questions that you see, that would be awesome. And there's Leah's question for Dr. Betof Warner I just saw in the chat as well. So if we can keep the discussion going in the chat, we're going to move on to Dr. Moshiri. So it's a real pleasure to introduce Dr. Atta Moshiri to the attendees. Dr. Moshiri is double boarded in both dermatology and dermatopathology. So he both sees patients as a practicing dermatologist, but also is a dermatopathologist and helps make the diagnosis of melanoma for patients after a biopsy. He was trained at University of Pennsylvania for his residency and dermatopathology fellowship. He is currently an assistant professor in our division of dermatology at the University of Washington, and has a very interesting talk today about kind of demystifying some of the pathologic aspects of melanoma. Dr. Moshiri, take it away.
Thanks so much, Dr. Hall, and thanks, Dr. Byrd, all of you for inviting me to sort of address this topic that is near and dear to my heart, and probably an area that we don't hear a whole lot about. But I'm going to go ahead and try and not break the streak here. Can you all see it? Awesome. Okay. So in addition to having the privilege of seeing patients, and I see some of my patients in the chat, which is wonderful, I also get to wear this hat of thinking about what's going on with skin specimens after they've been removed and put into a bottle, and really thinking about what we can learn about the biology of melanoma, and also how that will likely affect patient outcomes by looking at these things under the microscope. So the goal of my talk here is kind of twofold. One is to take you through the journey of what happens to your skin biopsy after it is removed from your skin and put into a bottle. And then also, probably more importantly, is how to read your melanoma pathology report and get some useful information out of it. So oftentimes, if you've ever had a skin biopsy in the past, there'll be a diagnosis line. They'll say basal cell carcinoma, and then that's pretty much it. That's important. But with melanoma, we oftentimes have a whole lot of writing that goes below that, with a whole bunch of different features and findings that can be confusing. And it actually especially important to understand this now is, recently there was a law that was passed in Washington State that basically dictates that these reports have to be released immediately to patients for review, oftentimes without even going through your ordering clinician or provider. And so you may very well get these reports without any other information. So I'm hoping to be able to arm you with some info that will be useful to review these reports and to be able to ask good questions from your doctors from them. All right, so the first part is, what happens to your skin biopsy after it's put into the specimen bottle? So I'm going to take you through a visual journey. In dermatology, we're a very visual sport. So the first thing that happens after the specimen gets plunked into the bottle and put into that biohazard Ziploc is it gets handed to somebody who's going to be responsible for transporting it to the lab. So that's usually a courier. Sometimes these are sent by FedEx or other traceable system. and rarely by the USPS. And we usually don't use that service unless it's through some very heavily traceable system. As you can imagine, you don't want to lose these specimens. And when it arrives to the lab, the first place that it stops is with the accessioning people. So this is a photograph of a couple of our accessioners. And their job essentially is to take the specimen and to create a identity for it in the electronic system. So what they do, first thing they do is they'll assign a number to the specimen, so a case number. And oftentimes there's a barcoding that's associated with the label that's attached to the bottle. And they'll sort of scan this in and create a case. The next step is that it will be handed to a grocer. So a grocer is essentially a technician whose job it is to measure the specimen and to handle it before it's sort of processed. And this is an example of what one of those workstations might look like, with some, cutting shears and plastic cassettes and fixatives and things along those lines. And so the first thing the grocer will do is they will record information. So for example, they will oftentimes draw the specimen in a schematic, and they'll write some notes about what it looks like after having been removed from the formalin in the bottle. And they'll take note of any sort of sutures or other markings that have been put in. They'll then measure that information. And so oftentimes at the bottom of your report, you'll get a gross description, and they'll say, it measured by, this many centimeters, by that many centimeters, by this many, and they'll report all that information into the case. They'll then cut that specimen into smaller pieces, oftentimes into a little, kind of like cutting a bread loaf. They'll cut slices. And then what they'll do is they'll ink it along the outsides of the tissue so that we can orient to know what is the bottom and top and sides and things like that. And then those specimens get placed into a plastic cassette like this. Okay. And so the cassettes then get placed into a tissue processor. And the tissue processor basically exposes the tissue to a whole bunch of chemicals that are then helping to preserve the tissue, but also to prepare it for staining so that we can look at these in an intelligible way under the microscope. So these are some of the processing machines, and they're pretty expensive. After the tissue is processed, it gets embedded in paraffin wax, okay? And so you can think of the embedding process. If you're a Star Wars fan, you can think of kind of Han Solo being embedded in carbonite. This is kind of what happens with your specimen. It gets embedded in this paraffin wax. And so this is actually what that looks like. Here are the chunks of tissues removed from the cassette, and they're put in this little metal mold. And then there's the paraffin wax that gets added to that. And then the tissue gets placed back into the cassette along with the wax. And oftentimes it's placed on ice to harden it. So here's the tissue being hardened in the wax. And then what you end up with is that that piece of tissue now embedded. And this cassette along with the wax in your tissue is what's called the block, or the tissue block. And if you had a small biopsy, all of it might fit into one tissue block. Or if you had a large biopsy or excision, you might require multiple blocks for the same specimen. And this tissue is held on to by the lab for 10 years. And so even though we oftentimes generate a report within a few days of having had the specimen processed and stained and looked at in this way, we actually hang on to these blocks for at least 10 years after the fact, in case any issues come up and they need to be re-examined, or additional studies or research questions can be asked. And so then what happens is that the tissue block gets put on a microtome. And this is essentially an apparatus that has a very sharp blade that's down here. And you can think of it like a super sharp deli slicer. And essentially this wheel gets rotated and the block moves up and down and little slices of tissue come off, just like this. So these are little ribbons of tissue that get sliced off, just like little deli meat slices. And then these get loaded onto glass slides, usually several pieces onto the slide. And this is oftentimes called a ribbon. And then this is what it looks like. You have several different ribbons put on each one of these slides. And then they get put through a stainer. And so once they're stained, they're oftentimes stained with two dyes in particular, hematoxylin and eosin. These are really old dyes, ancient dyes that were used for staining clothing and things along those lines to generate a beautiful sort of purple, blue, pink colorations. And this is the standard. So we look at these tissue sections stained with hematoxylin and eosin. And then the dermatopathologist gets the slides. This is how we receive them with those tissues cut and stained. And we usually look at them, usually not 7 people at a time, usually 1 person at a time, but we'll evaluate them and then generate reports. So this is kind of a blurry example of what normal skin might look like under the microscope. So this top layer up here is the epidermis. This is the outermost layer of the skin. It's this kind of thin purple wavy line up here. And then the second layer of the skin is the dermis. It's this very pink area that has these kind of whitish structures with these little purple buds. So these are hair follicles actually, and they're sweat glands. And the majority of the pink here ends up being collagen. So this is that kind of connective tissue of the skin that gives skin its elasticity. And then down deep, you have the fat. And this is the subcutaneous fat, essentially. So 3 main layers: epidermis, dermis, and the subcutis, or the fat layer. And what we do is we look for pathologic changes. So whether there are tumors, which melanoma is an example, or if there are inflammatory changes associated with some sort of rash, we mark those changes and we issue a report with hopefully a definitive diagnosis. So the question really is, what is the role of the pathologist in diagnosing melanoma? What do we do in all this? And what is your path report really trying to generate? And what I like to say is that we, as the pathologist, we put the T in TNM, all right? So this is an example of the American Joint Commission on Cancer melanoma staging system. So this whole staging system from the AJCC is kind of the definitive way in which solid tumors are staged. And this is really important to determine what treatments you get and sort of what kind of clinical course you can expect. And it turns out that the last sort of outgoing chair of the last edition of the AJCC is actually Dr. Byrd. So kind of a pretty important guy, 2 thumbs up. And so what the pathologist does here primarily is we're looking mainly at staging the primary tumor for the most part, unless we're getting lymph nodes or other tissues. But our job mainly is to look at the melanoma and to generate this T staging piece. That goes along with the nodal staging and then also distant metastasis to come up with your overall clinical stage, all right? And so we'll go over kind of some of those important elements. But beyond that, what we're also tasked with identifying are the prognostic factors for melanoma. So it turns out that there are a whole bunch of features that are supposed to be reported on a melanoma pathology report. And it varies a little bit by lab, but for the most part, you can expect to see some or all of these features on your primary melanoma. And so we're going to spend a little time going over these. But here they are. And what I've done is I've highlighted the most important features for you. So if you take away nothing else from the rest of this talk or from evaluating your report, I want you to be familiar with the concept of a Breslow thickness, whether or not there's ulceration, and then lastly, what is the pathologic stage and why that's relevant for you, okay? So the first element that you oftentimes will see is the histologic subtype. And historically, there are 4 main histologic or growth patterns for melanoma. We think of them as superficial spreading melanoma, which is the most common type, lentigo maligna, which is the type that usually affects older patients on sun-damaged skin of the head and neck, nodular melanoma, which is kind of a rapid growing bump, and then acral lentiginous, which is usually the kind that affects the palms and soles or the nail apparatus of the digits. So this is kind of a nice visual schematic of what those types are. The superficial spreading usually starts as a dark spot that has irregular borders and changes colors. Nodular melanoma usually starts as a raised spot that rapidly grows, usually up in size and not so much laterally. Acral lentiginous, as I mentioned, usually that kind of dark spot that grows on the palm or the sole. And then the lentigo maligna subtype is that large kind of sunspot looking thing that might have not been recognized early on in the course of the disease. So here are just some graphical examples. This is a good example of what a superficial spreading melanoma looks like on the skin. Multiple colors, black, red, brown, present in this one. This is an example of that lentigo maligna. So here's kind of that dark spot here and a lot of this muddy brown and maybe even some pink in the background. These are oftentimes a lot larger than they might look like actually to the naked eye. Here's that nodular melanoma, that big sort of bump that tends to grow up, can be a really rapid grower. And then here's that acral lentiginous melanoma. So here's that plantar surface of a foot with that very dark, irregular plaque. It's kind of stuck on there. So that's what the histologic subtype refers to. And there are other types too. And that element is not as important. What subtype you have is not as important for your treatment overall. So it's more kind of a classifying thing and less important for treatment. The growth phase, you might see some places report this. And basically there are two growth phases that are sometimes reported. One is the radial growth phase, which is the growth sideways. And then there's the vertical growth phase, which is growth downward. And much more dangerous is the downward growth of melanoma. So this is an example of melanoma in the skin. These atypical cells here, these little, almost like grapes hanging off of a tree in that top layer. And this is an example of melanoma in that top layer, that epidermis only. And there's none down here. This is all inflammatory stuff. And then this is an example of something very different. So this is that nodular melanoma. So lots of melanoma and tumor cells that are sort of pushing down, down, down into that second layer. But there's not really any melanoma that comes off into the epidermis. So this is kind of a true vertical growth phase for a melanoma. And then this is a mixed one. So this is melanoma here up in the epidermis and then melanoma down in the dermis. So this has both a radial and a vertical growth phase. All right, so now we're to one of the very, very important features, which is the Breslow thickness. So what this is measuring is how deep does the melanoma invade into the dermis? And we measure this in millimeters and we round to the nearest 10th. So an example is if we measure this at 0.64 millimeters, we'll report that as 0.6, but if you're at 0.65, we'll round that up to 0.7. And the way this is actually measured is from that top layer of the epidermis. We actually take a micrometer and we measure down to the deepest level of the invasion of those melanoma cells. And that becomes your Breslow thickness. And that's the most important feature that goes into your pathologic stage, okay? And I won't harp on things too much, but this is basically the staging breakdown. We have 4 major cut points between 1 millimeter, 1 to 2 millimeters, 2 to 4 millimeters, and greater than 4 millimeters as the depths that are the most important. It's gotten a little bit fancier as of the 8th edition in those thin melanomas. If you're more than 0.7, so if you're 0.8 to 0.1, that puts you kind of a little bit in that worst T1B category. But for the most part, you can think of it as these 1 to 2 millimeter breakdowns. All right. Clark's level, this is not an important feature for your melanoma. It's more of a historical thing, but it's really measuring how deep in terms of anatomic layer, which anatomic layer did the melanoma get to? So obviously deeper melanomas are more likely to get down to the fat and you'll have a higher Clark's level, and a lower Clark's level will be much shallower. But this, you don't need to pay too much attention to this feature. Ulceration is also very important. We know that this feature plays into your prognosis. So the question really is, did the tumor erode away the epidermis, which is that top layer of skin? And this is really a measure of how rapidly is the tumor growing. So rapidly growing tumors are more likely to grow deeper and to cause ulceration and to be more dangerous overall. So this is a schematic, and here's the picture, but here's that top layer, the epidermis, and you can see that there's this pink stuff, which is serum and blood, and it's eroded away that epidermis. And here's another example. This is a big nodular melanoma, and over the center, you have this ulceration. That's this pink stuff where the epidermis is eroded away. That's what it looks like under the microscope. And again, the ulceration is important because for a given depth, it decides whether you're an A or a B. An A is better, B is worse. So if you had ulceration, it puts you into that B category, with, again, a slight caveat to that, which is if you're on the thicker side of that sub 1 millimeter, so between 0.8 to 0.1, if you don't have ulceration, you're still in that T1B category, okay? Mitotic rate, this is important. So we look at the number of dividing cells, and even though it doesn't fit into staging, the higher the number of dividing cells, the more worried we are about the tumor, the more likely the tumor is to spread or to metastasize. And so this is an example. We actually look at these in very high power. We look at the cells and we look for the number of dividing cells. So this is an example of a cell that's dividing. Its chromosomes here are getting ready to split up, and this cell is going to become 2. So this is 1 dividing cell here in the sea of normal melanoma cells. Okay, just quickly, so lymphocapillary invasion, here we look to see, did the melanoma invade the blood vessels of the skin? And we worry about that because if it's present, it's definitely concerning for the possibility of metastasis. So this is an example of a blood vessel, this round structure with the white space and the red blood cells in there. This is a blood vessel, and this is the melanoma invading into that space. So this is worrisome because it increases the likelihood of there being metastasis from the tumor. Satellotosis is similar. This is asking, is there a cluster of the melanoma cells that broke away from the main mothership of the tumor? And this actually is pretty worrisome. It increases your clinical stage if this is present, because it's shown that the tumor is capable of spreading outside of its local environment. And so this is a difficult picture to see, but take my word for it. This is melanoma here off to the edge. And then here you have a cluster or chunk of tumor that's sort of spit off here off to the edge, far away from the mothership. So this would be a microsatellite. These are not common, but if we note them, it's important to know that they're there. Perineural invasion. So just like the blood vessels, we look to see if the melanoma invaded the nerves. And if it has, then we worry that the melanoma can actually track along those nerves. And you may end up getting scans or other things to look for that possibility if it's present on the pathology. So this is an example of a nerve. You don't have to know that, but sort of these are melanoma cells that are invading into that normal nerve. And so if we see this, we want to let the clinician know. The lymphocytic infiltrate. So the question here is the immune system attacking the melanoma? And the more inflammation, the better. And we report this. Is there a lot? So is it brisk? Is there some non-brisk, or is there no inflammation? And so this is an example of melanoma with a lot of these little inflammatory cells. This is all your immune system attacking that tumor. So this would be a brisk or a good response. Here's an example of a so-so response. So here are the melanoma cells and these tiny little blue guys that are hugging up on them. These are, you have a few immune cells. So this is non-brisk. And then here's melanoma with hardly any of the small blue cells around it. So that's pretty much absent. Regression. So did the tumor or did the immune system cause the tumor to go away completely? So this happens sometimes. Your immune system will recognize the tumor and maybe eat it, and all that we see that's left in the skin will be the shadow or the remnant of that. And it turns out there's some recent data that shows that presence of regression is actually probably a good sign. It means that your immune system can recognize that tumor, and you may respond better to immune therapy if that happens. So I won't waste time sort of talking about these features, other than to say this is an example of regression. So here we have a lot of pigment. The melanoma cells died and they left this pigment there, but there's no melanoma left. So this is essentially a regressed away tumor. We talk about the margins. Basically, is the melanoma still there? Is it present at the tissue edge on the margins, both on the sides and the deep margin? Here's an example of a shave biopsy of a melanoma. Here you can see at the tissue edge, there's still tumor, but underneath it, there's pretty healthy, normal looking skin. And melanoma in situ, is there melanoma in that top layer? This is something that oftentimes they want to know for the report, but doesn't usually affect what your clinical course is going to be. Of note, if there is no melanoma in situ in your primary specimen, sometimes we worry it might not have been a primary tumor, that it's possible it might have been a metastasis, but that's something that you and your clinician will need to talk and think through together. And then lastly, and most importantly, is the pathologic stage. So this number, which is most closely related to the depth, again, how deep did the melanoma get, is going to determine sort of how risky your tumor is and the likelihood of it posing a threat to your overall health. So the higher the stage, the higher the thickness, the greater the likelihood of metastasis over time, and the greater the danger to your overall health. So you can see that here, that you have the clinical stage listed here. The higher the number, the more advanced your disease is. And you can see that the pathologic stage, the higher that number goes, the higher your clinical stage goes. But you can only get to clinical stage 2 disease with your primary tumor. You're going to need your nodes or distant organs involved to get higher than that. And we know that looking at patients with clinical stage 1 or 2 disease, over time, the thinner your melanoma is, the more likely you are to do well with it clinically over time. So here I have, this is representative data. This is melanoma specific survival in years. And we see that people who have thinner tumors tend to do a lot better. People who have thicker tumors tend to do a little bit worse. So last thing I want to do is put a plug in for the Melanoma Institute of Australia Risk Prediction Tool Calculator. I recommend this to some of my patients who are interested. Some people don't want to know this information at a granular level, but for those of you who do, I would recommend taking a snapshot of this and checking it out. But a lot of the premier data for melanoma comes from Australia. It's their national cancer, also out of Denmark. And they've built these cool nomogram tools where you can put in your information, your age at diagnosis, your features, your skin type, your family history, your pathologic data from the report. And you can calculate things like your risk of melanoma, your risk of having a sentinel lymph node metastasis, or your subsequent risk of melanoma, meaning getting a second one, or a hot topic these days in the literature is what is your risk of metastasis from a thin melanoma? Because even though it's rare, it does happen, and those are the cases that we want to be able to identify. Lastly, I'll just say very briefly that the field is moving away from classifying these tumors just based on how they look under the microscope, and moving towards understanding the genetic alterations that are present within a tumor, and to think about these melanomas based on their mutations. And we know, for those of you that are familiar with the BRAF pathway, we know that there are drugs that are available to target these mutations if they're present in your tumor. So topics we didn't cover today, we didn't talk about some of the rare subtypes of melanoma, like desmoplastic melanoma or Spitz melanoma, or some of these less common ones. We didn't talk about diagnostically ambiguous tumors, like the maybe melanomas, the pathologist wasn't sure. And we didn't talk about some of the newer testing that's in the process of being developed. For example, Castle Biosciences has one such test, or about the specific impact of having certain mutations in your tumors. But hopefully, you know, I'm happy to answer questions either here or offline. And I'm sure some of our other speakers will address some of these topics in their talks as well. Sorry for going too long on that one, but thanks for indulging me.
That's a fascinating talk. I didn't know most of that stuff about what actually happens after the biopsy happens, so I found it very informative. I suspect a lot of people on the presentation did as well. Dr. Byrd has a question, and then I think after he asks, there's a lot of participant questions for you in the chat. If you wouldn't mind answering those in the chat, and we can then move on to our next talk.
Happy to.
David, go ahead, and then we'll move
Absolutely.
on to Dr. Kim.
Great, thank you. Atta, great talk as always. I'm a little distracted because the Ray show is going on in the chat. Ray, your talk was so phenomenal. We could almost take half the audience and send you elsewhere, and the rest of us go on with the rest of the day. Yeah, you are phenomenal, and
I would be in that group.
Now, in saying that about Ray, Atta, yours was a great talk. I have a question, and it relates to, you said specimens are kept for 10 years. The idea is that something may come up from a study point of view of archival material, and how is that relevant? I'm fairly frequently asked by patients saying, should some of this be kept sterile and in a safe place and not put in paraffin? And could you comment on the looking forward at the ability to do, for example, genetic testing on formalin fixed paraffin embedded material, and that is not lost by putting it into that, versus moving toward either fresh tissue or maybe liquid biopsies that Dr. Hall is going to cover later on?
Absolutely. So this is a great question. So that 10-year requirement to keep specimens is largely a sort of a certification requirement for pathology labs in order to be able to basically ensure that tissue can be reviewed from a clinical perspective during that 10-year period of time. So for example, if the diagnosis ever came up in question, or people wanted to do an additional test to re-review, you have to keep the slides and the block ready for basically clinical re-review. That's kind of a standard along the way. There's no requirement clinically to keep any sort of fresh tissue. So oftentimes when a biopsy is done, it's done mainly from the clinical perspective of, we want to get a diagnosis of this tumor on the books. Fresh tissue is oftentimes acquired for the purposes of being able to do particular research analyses, and less frequently do we need fresh tissue for actual diagnostic purposes. But certainly a lot of the important clinical, or rather research questions that we want to be able to ask do require fresh tissue. So the good news, to get to your question directly, is that a lot of our sequencing testing is now able to be done on paraffin embedded tissue within the block. So that's the important point, is that we're moving towards being able to do more of these tests on the wax specimens, which is really nice. We have a lot of researchers at Seattle Cancer Care Alliance and elsewhere who, and if you're involved in a given protocol, oftentimes when you do give a biopsy, we also are sending some of that fresh as well, so that we can do some of these more experimental studies, but it's not done routinely as part of just clinical diagnosis.
Great. Wow.
Did that answer that question?
This is a great talk. There's lots of good questions for you to tackle in the chat, and some of which are late to staging.
Good.
And I think Dr. Kim it's a great segue for Dr. Kim. So our next speaker is Dr. Teresa Kim, who's a surgical oncologist at the University of Washington Seattle Cancer Care Alliance. Dr. Kim, like many of our speakers so far, has exceptional training and pedigree. So she was trained at Massachusetts General Hospital in her surgery training, and then went on to do a tumor immunology fellowship at Memorial Sloan Kettering. She really is a surgeon and a scientist. and really excited that I get to work with her on a daily basis in the care of our melanoma patients, and that she's going to speak to us today about surgery and melanoma, kind of what's new on the horizon, and also just some basics about what we do when someone's diagnosed currently. So Dr. Kim, take it away.
Thanks, Evan. I'll try not to be the first one to screw up the screen share here. All right, perfect. How is that looking?
Go with, yeah.
Excellent. So as Dr. Hall said, I'm a surgical oncologist here at SCCA, the University of Washington. And I basically wanted to give you a snapshot of where surgical treatment of melanoma is, and with all the major advances in science that have happened, especially over this past decade, where hopefully will continue to grow. So I don't have any financial disclosures. As Dr. Hall said, I'm a little bit of a science and immunology nerd, so this is near and dear to my heart. And I am also a wife and mother of a crazy toddler, which is why I'm in the office today. For the next 20 minutes, what we'll do is just review the basic tenets of melanoma surgery as we practice today, and then some of the relevant scientific breakthroughs that are hopefully going to give us a path to the future. As a really, I think, basic take-home point, surgery does often cure patients with localized melanoma. So it is an incredible privilege to have this as our work. And basically about 80% of patients who we see coming through the surgical oncology clinic have melanoma just in one spot that we can excise with wide skin margins and then lead to long-term cure. And that's captured in these upper survival curves especially. The issue is that in surgery, as well as any kind of treatment of cancer, where we were and /are right now today is kind of a crude approach to cancer, trying to treat everybody as one size fits all. And what we're finally learning from a lot of tumor profiling and genetic studies is that individuals are very heterogeneous, meaning different from person to person, even with the same diagnosis like melanoma. So there are treatments, including surgery, that we administer that don't benefit patients, or maybe too much or too little for a patient's particular amount of disease, and carry with it sometimes adverse effects in addition to no benefit. So what we're hoping to get to someday is this big umbrella of an approach called precision medicine, where with extra testing, beyond the really great features that we already get from a pathology report, microscopic review, and review of somebody's medical history, if we can get extra omics studies done, what kinds of special gene mutations are in a tumor or protein expression, and get to a much more specific way of deciding what treatments are best and going to be the greatest chance of cure. So I thought that what would be helpful is to go through a few different scenarios, which you may fit into, that we see frequently on the surgery side of the clinic. Patient A being somebody just with melanoma in one spot, which we call localized. This would be akin to stage 1 or 2 melanoma. A patient with what initially seems like localized melanoma, but has microscopic spread to the nearby lymph nodes. And then a patient with what we call bulky lymph node spread, meaning a little bit more melanoma metastasis to the neighborhood lymph nodes. So to start with the first case, this is a woman who's 46, otherwise very healthy, has had fair skin and sun exposure with some blistering sunburns in the past, and came to clinic with a very irregular spot on her right upper arm that was recently changing, and was biopsied, as Dr. Moshiri carefully described, showing features that included a superficial spreading type of the histology, a 1.2 millimeter thickness through the skin layers, no ulceration, but a finding of 1 mitosis per millimeter squared. And so with all these features put together, she had a tumor or a T category score of a T2A on that scale of T1 to T4. And so in this setting, with this T2A melanoma, nothing else visible or palpable, meaning anything that we could feel on physical exam with attention to the lymph nodes, we see this quite frequently, and management is primarily surgical with a wide excision and maybe a sentinel lymph node biopsy. So this is what I'll talk in a little bit more detail about. This is just a review of what you saw a couple minutes ago, looking at the layers of the skin, this really does direct our surgical decision making. And this is just one more way of looking at the somewhat complex tumor staging that is our roadmap as surgeons to tell you how much surgery that you need. So for this patient with a 1.2 millimeter thick melanoma, she falls into this intermediate thickness category. 1.2 millimeters is not that thick, but on the scale of melanomas, it's middle of the road. For this, we would recommend excising or removing surgically that melanoma with a 1 to 2 centimeter margin of normal skin all around. And this is to make sure of two things: that we get the melanoma completely out, and if there are any little satellites, as Atta had shown, that we remove all of that as well. We often have to fashion these incisions in this football or eye-shaped way to be able to close the skin without edges sticking out like dog ears. And so this is just a diagram that a group really carefully looked through and measured across hundreds of incisions where tension was the least in terms of the orientation on the skin and the body. And so we think about these tension lines and forces. I never thought I would think about this in terms of physics, but in an initial clinic visit with a patient with a newly diagnosed melanoma, we gauge a sense of if this is in a spot, for example, like our patient in the upper arm, where there's going to be enough stretchiness of skin to allow for that primary closure, even with taking out the extra skin, or in rarer circumstances, particularly in areas of the body where there's not as much stretchiness, for example, the soles of the feet and the palms of the hand, where we have a really wonderful plastic reconstructive surgery group who are able to do amazing things, closing sometimes very large holes that we leave. And so this is an example where there was no way we'd be able to bring the skin edges closed from this melanoma removal from the heel, but our plastic surgeons were able to take very robust skin from the arch, which is a non-weight bearing part of the foot, use that to close the heel, and then put a skin graft onto the arch, which heals much better. And so this is a really great part of the multidisciplinary team we have with our plastic surgeons. I will say, as an aside, many patients come in asking, do you really have to do this if the biopsy said it got it all, negative or clear margins around the edges? And unfortunately, one of the limitations that we have right now is that we can't see microscopic tumor cells with our naked eye or with any kind of technology in the operating room. And I would say that there are groups working on this and have been working on this for quite a while. And nothing is close to prime time, but it is the hope that we get there someday, because not only for melanoma surgery, but a lot of soft tissue cancer surgery would be, I think, quite a bit better improved with that technology. So stay tuned. In terms of the other question, again, intermediate thickness melanoma patient coming in, should they get staged with a sentinel lymph node biopsy? This is a second part of surgery that we sometimes recommend for patients with a localized melanoma. And it's basically the most accurate test to check the neighborhood lymph nodes for if there's been invisible or microscopic spread. So it's more accurate than a PET scan or an ultrasound. And the way we do it is at the time of surgery, we inject a couple different dyes, a blue dye and radioactive tracer. And our radiology colleagues in nuclear medicine actually take some pictures for us before the operating room to show us where the dye concentrates into what is essentially the first or sentinel lymph node upstream of where the melanoma is. The lymph nodes are all across your body, connected by lymphatic vessels, highways of vessels that function to filter your body and fight infection. So they're part of your immune system. But skin cancers like melanoma can hijack that system, particularly if they have higher risk biology. And that's why we offer this second part of surgery to really fully investigate where there might be invisible spread. Right now, our national cancer guidelines recommend that for any melanoma patients at that 0.8 millimeter thickness thresholds or with ulceration should have a sentinel lymph node biopsy, or at least strongly consider it to really fully get the information about their lymph node status. What's important to know is that it's really a test and not a treatment. And so we do counsel patients about this quite a bit. And this is based on a surgical trial from many years ago now, but it was really informative, which showed that a sentinel lymph node biopsy procedure does not help your chance of survival from melanoma, but it does give really good information about if you need extra surveillance, if you need extra treatment after surgery. So it's really informational. What we're hoping to get towards, and Dr. Moshiri mentioned this nomogram calculator, is we look at, as surgeons, we see melanoma patients with kind of fuzzy glasses. So we have the pathology report features. We know things like ulceration and thickness determine lymph node risk, but can we get a little bit kind of a higher definition prediction of if there's going to be a lymph node metastasis or not? So some of these nomogram calculators, which big high volume centers have created from studying hundreds and hundreds of patients with melanoma, take into account several additional features that have frequently been seen to also predict lymph node spread, like the subtype or the kind of appearance under the microscope, the mitotic rate, so how actively dividing they are, and if there's any red flag like invading into the lymph vessels. And these calculators have their own limitations, but if you are looking for increased granularity of information or prediction, I have found them to be quite helpful in patients in the gray zone where they're quite low risk and trying to decide if they really want a sentinel lymph node biopsy or not. The flip side of having that surgical test is that there is a slightly increased risk of lymphedema, which we'll talk about later. So we want to always weigh the risks and benefits of a treatment we offer. The other test that Dr. Moshiri mentioned that is wrapped in a little bit of controversy right now is all of the things that are considered gene expression profile testing. So there has been a huge revolution in technology to study gene expression. So DNA is kind of the roadmap for cells in your body to instruct them on what to do. And RNA is the translation of those to get to protein. And now there's technology, as Dr. Moshiri said, to look at even just those wax blocks of tumor biopsies and measure all kinds of things like gene expression in a particular set of genes that might predict bad or risky behavior or metastasis. The issue is that they've not been fully studied and vetted, and so it is not exactly clear how to incorporate this into your decision making. Should I have a sentinel lymph node biopsy or not? But there are more and more studies that are coming out, and so this will hopefully in some iteration be a test of the future that will again just finer tune our decision making around how much surgery that you need. So for this patient, intermediate thickness melanoma just on her right upper arm, she had a wide excision with the primary closure and the 1 centimeter margins. She had a sentinel lymph node biopsy that was clear, and then she was able to just go on to surveillance. The second patient that we wanted to talk about is basically just remember that same patient, but sentinel lymph node biopsy unfortunately showed one of two right axillary, meaning underarm lymph nodes that were involved. The lymph node that had the melanoma metastasis only had a very tiny amount of metastasis, less than 1 millimeter, and no bad feature called extranodal extension, which is tumor invading through the lymph node capsule. So having the lymph node spread does make this person considered to have stage 3 disease, but very low risk stage 3A disease. So the question is, what should we do next? The thing that we always do first, if we see that melanoma spread to the lymph nodes, is get what we call staging imaging, meaning ruling out any other spread elsewhere, since the risk is higher if melanoma has already traveled to the nodes. In this case, she had a CT scan of her whole chest, abdomen, pelvis that was negative otherwise. And she had some tumor testing for the gene that Dr. Moshiri had mentioned, BRAF, that's mutated in about half of cases, and that was normal or wild type. So about maybe 5 years ago, if she had come to our clinic, the next surgery that we'd recommend is actually a much bigger lymph node surgery called a completion lymph node dissection to remove any of the other lymph nodes in that right armpit basin. microscopic melanoma. But the downsides of this are that there is an even higher risk of lymphedema or bad swelling downstream of the arm with taking out all the lymph nodes in a lymph node basin. And in fact, you're not helping the majority of patients who don't have any extra melanoma in the additional lymph nodes, and you're not helping the patients with the really high risk disease who have already spread to somewhere else like the lungs. So it's only a very small percentage of patients with kind of lymph node limited disease. So it was a little bit of a caveman approach. And then a huge practice-changing trial called the MSLT2 trial was just reported several years ago in 2017, and it really has changed practice. And basically, as this graph is showing here, that completion lymph node dissection surgery led to a lot of side effects and morbidity like lymphedema, but did not change anyone's survival at all. And so we realized that this was not helping people for all the reasons that we just talked about. And we instead recommend active surveillance, not saying forget about your melanoma, you're done, but come back frequently every 4 to 6 months, have a physical exam and an ultrasound or careful imaging of your lymph nodes, and that these patients do just as well. And interestingly, just in the past couple of months, studies have come out that are real world assessments of kind of this post MSLT2 world that we're in right now. And they have shown that there's no difference in recurrence or survival mainly that they've seen in patients who have gone on this surveillance path instead of completion lymph node dissection. So hopefully we're sparing people a lot of lymphedema. At the same time that the surgical trial was reported, there were a number of preliminary reports of medical treatment after lymph node positive disease is detected. This is called postoperative therapy or adjuvant therapy. And as you can see in this bottom graph, these trials are still ongoing, but early results are at least showing that recurrence, meaning regrowth of melanoma after a year of medical treatment like immunotherapy after surgery, can really cut down the risk of regrowth, or basically in this sense, increase your chance of being alive with no melanoma coming back if you're in this blue arm, which is receiving a year of treatment after your surgery. So these categories of trials have really changed the way that we approach patients with the microscopic lymph node spread. And we're trying to be a little smarter about tumor biology instead of doing the one-size-fits-all treatment. There are further questions like a stage 3A patient like our case B, do they really need medical treatment? Or in fact, is their outcome going to be so good that it's not worth the side effects of treatment? And on the flip side, for a small category of stage 2 patients with no lymph node spread, but bad tumor biology just in that localized primary tumor, do they actually need some medical treatment afterwards? And these are things that are actively under investigation. But for this patient, again, with very low risk features of her primary tumor and only a tiny bit of sentinel node metastasis, she opted for surveillance. So the last case that we were going to talk about is really the highest risk patients with what we call regional disease, where they come in with a melanoma diagnosis, as well as lymph node spread that they felt on exam or that we felt in the clinic. These patients have a higher risk biology of their tumors that we want to smartly throw the kitchen sink at with our whole multidisciplinary toolbox. So that's surgery, medical treatment, and sometimes even radiation. So a different iteration of this patient that we're talking about is that she had an intermediate thickness melanoma just diagnosed of her arm, but at the same time felt a big mass more than an inch in size under her armpit lymph nodes. And so she underwent 2 biopsies, one of the arm lesion to confirm the melanoma, and then a needle biopsy of the enlarged lymph node that also confirmed metastatic melanoma. In these cases, again, we get a scan, either a CAT scan or a PET scan, to make sure there's no spread elsewhere. Luckily, she did not have anything. There was just an enlarged lymph node in the right axillary or armpit basin. And she also had her tumor BRAF molecular testing that did show a BRAF mutation. So in this case, the standard surgical treatment for somebody coming in with that bulky amount of lymph node metastasis is a full or therapeutic lymph node dissection. And we frequently see these as shown here in the underarm axillary region or in the groin pelvic region or in the head and neck as well. And the goal is to remove all of the lymph node tissue in its fatty envelope from either the underarm or in this case, the groin, and then the deeper pelvic lymph nodes. There is a lot of development towards minimally invasive surgery across many surgical fields, including these groin lymph node dissections, which can be really hard from a wound healing standpoint. So we're not yet doing minimally invasive lymph node dissections for the groin for melanoma patients here, but our urology and GYN colleagues are doing this now, and it's something that we hope to develop soon. The problem with these surgeries is that there is a really high risk of lymphedema. It's about 20 to 30% from the arm, and even higher, over 50%, some are quoted, in the leg groin region. So there are many things that we are trying to do to either prevent or treat lymphedema before it gets to a severe stage, which is life-altering, quality of life-altering. We're working with a really wonderful physical therapy team at the SCCA who have lymphedema trained specialists to do a screening pilot to actually measure people's arms or leg size before lymph node surgery, and then periodically for 2 years afterwards to pick up subtle changes that might allow for initiation of treatment before severe swelling sets in. Our plastic surgeons not only are able to close big holes really wonderfully, but also are gaining experience in a procedure called lympha, or lymphatic microsurgical preventive healing approach, where at the time of lymph node removal, which we perform, they can actually hook up cut lymph vessels to blood vessels to kind of restore flow here. So not all patients are eligible for this, but this is a technique that I think is going to, again, hopefully decrease the potential side effects of lymph node surgery. And then our physical therapists who are trained in lymphedema are also able to administer treatment if patients do develop it. And this includes compression dressings, as well as exercise and manual or massage therapy. So our patient underwent a therapeutic axillary lymph node dissection, was found to have 220 lymph nodes that had metastatic melanoma, and then had medical treatment after surgery. The problem is that she remains at really high risk of recurring, especially as you look at patients with stage 3C or 3D disease in the orange and red curves here. We have a lot of room to improve treatment and outcomes. So amazingly, in the past 10 years, there's been this explosion of medical treatments that has followed the understanding of melanoma biology, both with the tumor signaling inside the tumor cells with the BRAF and MEK pathway, as well as the rest of the cells in the tumor microenvironment, like the immune cells, the T cells, for example. And so these are medicines that Dr. Hall and Dr. Bhatia and our medical oncology group have a lot more experience with that you'll probably be hearing about later. But the goal is to take all of that knowledge and bring it from stage 4 and kind of apply it to the stage 3 setting, like this patient needs, to see, is there some better approach that we can take sandwiching medical treatment and surgical treatment together to not only improve the chance of survival or cure, but also decrease the surgical morbidity or side effects like lymphedema. So there's a ton of clinical trials right now that are looking at what's called the neoadjuvant approach, doing a short course of medical treatment like immunotherapy before surgery, looking at response, and then deciding on how much surgery and how much medical treatment is needed afterwards. So this is all under investigation right now, and hopefully within the next couple of years, we'll have much better answers for what the right move is. But that's basically where we're at with melanoma surgery today, and hopefully in the future. Surgery is the mainstay of cure for localized melanoma, but we're trying to fine tune our approach to problems like lymphedema and better assessment and alteration of biology in the higher risk stage 3 patients. So I just wanted to say thank you to the Melanoma Research Foundation, and of course, all of you patients. You really inspire us and tell us exactly what we should be working on. And there's a great multidisciplinary team that it's a really privilege to work with. I'm happy to take any questions.
Great. Thank you. That was really built on some of what Dr. Moshiri talked about. It's very exciting to hear about all the things that we're doing on the surgical end to hopefully make our lives better for patients after surgery. And sometimes maybe doing less surgery up front might be the right thing to do and help them live better and have fewer complications. That's great. There are a number of questions in the chat. I think in the interest of staying on schedule, if you wouldn't mind tackling those in the chat, that would be great. And then I would propose we take a few-minute break. And so at 11:35, we will return and I will be speaking, followed by Dr. Bhatia, and then we will wrap things up. So we'll have a 7-minute break and we'll return at 11:35. Thank you, everybody. Right. It is 11:35 and I want to be respectful of everyone's Saturday. So I think we'll go ahead and proceed with the program. Let me share my screen because I am up next. Is this displaying okay for everyone? Great. So my name is Evan Hall, and I'm one of the melanoma medical oncologists at the University of Washington and Seattle Cancer Care Alliance. And I've really enjoyed today's program. I think you're going to hear some themes in this talk that build on what Dr. Kim was just talking about personalizing care and really thinking about how we can deliver more care to people who would benefit from it, and also think about how to spare treatment from people who don't need more care and are not going to have cancer problems in the future. And that's, I think, where circulating tumor DNA may take us. And so the title of this talk is Circulating Tumor DNA for Melanoma Disease Monitoring. I have no disclosures. So circulating tumor DNA, it sounds kind of complicated. It's 3 different words that are all a little bit strange, and then they smush together and are often referred to as ctDNA. And so what is this? We just need to start out, get on the same page about what is circulating tumor DNA. Circulating tumor DNA, so we'll just take it by pieces. Circulating means that this is detectable in the blood or plasma. So this is something that's circulating throughout the body in the bloodstream. Tumor, so this is a substance that's arising from the cancer itself, not from your normal body tissues. And so this is a distinction that we'll continue to make throughout the talk, but this is something that's specific to the cancer and not something that's happening in the rest of your body. And then DNA, which is our genetic material and is a component of all of our living cells. And the way this gets into the bloodstream is generally that cells naturally turn over and die. Cancer cells are no different. And when this happens, some of the DNA can get into the bloodstream and then circulate around. And so therefore, we kind of have this idea of circulating tumor DNA. And we'll go through this in a few more slides to make sure this makes sense. So tumor DNA needs to be differentiated from normal DNA. So during the process of becoming cancer cells, cancer cells acquire a variety of genetic changes in their DNA, which makes their DNA different than our normal body tissues. And these changes are called mutations, which may be a term you've been familiar with and has already been mentioned a few times today. And for example, in melanoma, a key gene that can be mutated is called BRAF or BRAF. And so sometimes these melanomas are specifically called BRAF mutated melanomas. And if they don't have a BRAF mutation, they're often called BRAF wild type melanomas. But this is one of a variety of mutations that melanomas can have that lead to them becoming melanomas and becoming cancerous. And these mutations that accumulate in the DNA of the melanoma cell are how the tumor DNA is different from your normal DNA, which you inherited from your parents. And so this is a key concept as we move forward. So as a bit of an overview, I kind of designed this schema to help us understand what is ctDNA exactly. So this is a schema of a patient with a melanoma cancer on their left leg, as identified by the dark star. And what we know is that melanoma cancer is surrounded by normal tissue and that there are lots of blood vessels depicted in the middle here in this red box that run nearby. And in cancer and in the normal tissues in your body, there are cells that are growing and naturally die. And when they die, they release their contents into the tissues nearby, and those can get into the bloodstream. And so the DNA released from the cancer cells that gets into the bloodstream is depicted here in these dark helices, one on the right side here and one on the left side over here. And then the DNA from the normal tissue that also has a natural life cycle from these cells that naturally grow and then naturally die at certain times is released into the bloodstream, and that's in green. And so what we're going to talk about mostly today is circulating tumor DNA. So this is the dark helices. But there is also circulating normal DNA in our bloodstream, and that's in the green. And so the goal is to see if we can detect circulating tumor DNA in the blood. So we're really trying to see if we can identify these dark helices. We don't care as much about the green because those are present in everybody. And so this is a schema of how this works, and we'll go through this in more detail. So how does this actually work? How is this currently being used in cancer care, and how might it be used in melanoma care in the future? So it's been shown in other kinds of cancer, mainly in colon cancer, that after a surgery with a goal of removing all known cancer, in this case, usually a surgery to remove part of the colon, if 30 days after surgery, if ctDNA or circulating tumor DNA can be detected in the bloodstream, those patients are at a much higher risk of having future cancer recurrence than those who can't. And really the reason for that comes back here. In order for there to be ctDNA in the bloodstream, we think that there has to be some microscopic deposit of cancer that is then seeding the bloodstream with tumor DNA. And so for people that don't have ctDNA detectable, we can't detect that process happening. Whereas for people that do, we can. And we know that in colon cancer, if we look at one time point, a month after their surgery, about people who have the positive detection of ctDNA are 7 times more likely to have a recurrence or a relapse of their colon cancer than people who don't. And so that's really, colon cancer is kind of where this has been studied most closely, but there's nothing specific about colon cancer that tells us this wouldn't also be useful in other cancers. And it's become very interesting to look at in a variety of cancers and may change practice. This is an example of melanoma patient, actually. So this is a patient with metastatic melanoma who started immunotherapy right here at time 0. So this is a graph that has the x-axis here is how long the patient had been on treatment, from the beginning of treatment at 0 months to 10 months and 20 months. And on the left is how big the melanoma they had in their, I think it was in their lungs for this patient, was on a CT scan. And on the right is what their ctDNA level was. So how much of the circulating melanoma DNA that could be detected in the bloodstream. what we can see is in this patient who had multiple scans and multiple ctDNA checks over time, they had their ctDNA fall dramatically while they started melanoma treatment with immunotherapy and remained low. And this actually happened far faster within the first month or two on treatment. It actually took them almost 20 months for the melanoma to shrink to its maximum shrinkage on a scan. And so it actually may be that the levels of ctDNA that change in the tumor might actually happen more quickly than how things look on scans when we're measuring the sizes of metastatic tumors, which is what we currently do to see how treatment is working. So this is an example of one way in which this might be useful in the future. So in terms of how we think about melanoma care, I think there are a couple possible ways that this technology could be used in the clinic in the future. One is for exactly the kind of patient that Dr. Kim was talking about in her last talk. Patients who have completed surgery and, to the best of our knowledge, have no detectable evidence of residual melanoma by our best scans, things like PET scans or CT scans, by our physical exam, we really can't detect any residual disease. Yet we know that some patients in that situation over time are destined to have melanoma regrow to the point that we can see it on scans and we feel new nodules or lumps. And so it's possible that for those patients, just like in the colon cancer example a few times ago, we could use ctDNA tests and possibly identify a group of patients that are at a higher risk of having a recurrence. Patients that have detectable ctDNA may be more likely to have a recurrence than those who do not, and they may be more likely to benefit from more aggressive treatment at that time. At the same time, patients who don't have ctDNA may identify people who are at a lower risk of recurrence, and that could help inform their discussion about more treatment after surgery. And I think overall, this has the potential to allow for more personalized, tailored care. And we'll use an example in a second to reinforce this. For patients with metastatic disease or melanoma that has already spread to other organs, the ctDNA test may eventually give us complementary information to that which we get from scans to help us determine if a given treatment is having the intended effect. So one scenario that we can just describe how this might be useful is in the post-surgery setting. So as you've heard from Dr. Kim, for many patients who have melanoma, surgery is a curative procedure. Many patients are cured with surgery alone. And for patients with stage 1 melanoma, the very lowest risk, their recurrence rate might be in the single-digit percentages. It may be very unlikely for them to recur, but it's not 0%. And as Dr. Kim pointed out, for people with multiple large lymph nodes at the time of their original surgery, patients with stage 3D disease, they may have a recurrence risk as high as 80%. And so the stage that we get from doing surgery provides us prognostic information, but beyond this stage number, it doesn't really tell us who are the patients that we are most worried about having a recurrence. And that's yes. So I'm going to use an example to help reinforce this. Judy is a 48-year-old female patient who was recently diagnosed with stage 3A melanoma of the left arm and her left axillary lymph node. And Judy is I made up her case as an example. This is not a real patient. So her skin melanoma was about 1.9 millimeters thick without any ulceration. So a PT2A, and her melanoma of the lymph node had a small amount of melanoma, about 1 millimeter. And so this would give her what's called a PN1A. These two pieces of information together would classify her as a stage 3A patient. After her surgery, because of the lymph node finding, she had additional scans, and she was found to have no evidence, as best as we could see, of any metastatic disease.
Evan, your slides have frozen and your face is frozen,
Yeah.
but we can hear you just fine.
Okay, let me see. Let me just, that's strange. It has frozen. My computer has frozen as well.
We
I
can
start.
hear you though. We can hear you fine.
Okay, well, I know what these slides say, and if it unfreezes, then I can re-pull it up here. Let's see. So the next slide was actually a diagram of 100 people like Judy. So 100 100 women or 100 patients like Judy. And at the time that I see them in clinic, they all are similar. They all have stage 3A disease. And we know that overall, over the next 5 years, perhaps 20 or 25 women or patients are destined to have a recurrence of their melanoma. But we don't know at that initial visit, who of those 100 people are those 20 or 25 patients who are going to have that happen. And so we often talk about reducing risk, but we know that not everyone is going to have their melanoma come back. And so one way in which circulating tumor DNA might be helpful is to help us try to identify at least some of who those 20 to 25 people are earlier on in their treatment, so we could think about giving them more treatment and perhaps identify some people who are at a lower risk of treatment so that we don't have to give them as much treatment. They may be able to be spared some of the side effects. Dr. Kim talked about some of the side effects of surgery. Our melanoma medicines are no exception. Our immunotherapies are very powerful, but they can have very powerful side effects for some patients. And I know many on the call have experienced those. And so we really only, in a perfect world, we would only use them for people that we were worried it had a high chance of this coming back, of the melanoma coming back. And so it would really allow us to tailor our therapy more specifically. Can everyone still hear me?
Yes.
Okay. This is interesting. My computer is completely locked up, but I can still, as long as you guys can still hear me, I can keep talking. I apologize for the slides. I will make sure that they can get sent out to everyone afterwards, because I think some of these pictures are quite helpful in explaining
Evan,
some of these concepts.
Do we have slides? Maybe Ritu has slides and she can project.
I didn't send my slides to Ritu, unfortunately. I didn't anticipate this happening. Let's see. Yeah. Well, I don't know. Maybe I think these would be helpful. Actually, I'm going to propose the following. Dr. Bhatia, I can hear you. I can't see you because my computer's frozen. I'm going to log back into the meeting. Perhaps we can do my talk will be in 2 parts, and I'll rejoin the meeting, and perhaps you can start and talk about your metastatic, the care of metastatic patients. Is that okay?
Yeah, I think that should work fine.
So I'll introduce you, and then I'll shut down and reload and rejoin. It's my privilege to introduce Dr. Shailander Bhatia, a medical oncologist in our group who cares for melanoma patients. He is a really amazing colleague. I've learned a tremendous amount from him in my 2 years at Seattle Cancer Care Alliance. He's also the clinical director of our skin cancer medical oncology program. And I can think of no one better to give a talk about the care of treatments with metastatic disease than Dr. Bhatia. So Dr. Bhatia, take it away.
Thank you, Evan. So I am now trying to share my screen, and it says you cannot start screen share while the other participant is sharing.
Well, that's interesting. It would have to be the organizer who caused all the problem. Everyone else was able to navigate this, but not me. Let me. I'm going to shut down. So you guys can just, hopefully it'll free it up. All right.
Sounds good. Thank you, Evan.
An awkward spot that many of us have been in before. He will be back.
What will a Zoom meeting be without some technical hassle?
Why don't you go ahead? Oh, you can't. You still can't.
This is remarkable.
He couldn't even leave for a minute.
Okay, now I can. So let's see here. Do you see my slides?
Got them.
And do you hear me okay?
Yes.
Yes.
All right. Great. Well, my intro was going to be that, I'm going to be the last speaker. You have to go through me to get your Saturday back. But, I think Evan stole that pleasure away from me. So I want to start by, first of all, thanking you, David, for leading this symposium all these years. I have to say that, of all the talks we in the academic side do, this is really what matters. This is why we do what we do. It's all our research, all our expertise is for our patients, and it's so fun to talk to our patients outside of the clinic and just convey how we think about the disease. So as a medical oncologist, there is so much going on in the melanoma world that it's almost impossible to summarize it in 20-25 minutes. We are already running behind time. So, and there's so much to cover, so many trials going on, so many exciting approaches that, we'll definitely be missing out on something. So what I thought we'll do is I give you my perspectives on how to see the disease of melanoma. So this is really a medical oncologist viewpoint. How are we thinking about the disease? What's going on in our minds when we are recommending one treatment over another? So I just want to remind by saying, people in the panel definitely know this, but many people in the audience can probably relate to this too. Skin is actually, we don't think of skin as an organ, but it is actually the largest organ in the body. And by virtue of its location on the outer side, it takes all the insults that we can think of. It's being exposed to UV and many other insults. And so it's no surprise that it's most vulnerable to cancer development. These figures may not be correct, but if you look at, I think it will give you a flavor of skin cancers in general. So the inner circle shows the incidence, how many cases are being diagnosed of a particular skin cancer every year. And the outer circle shows mortality. The main point I want to make is basal cell cancer and squamous cell cancer, which many patients on this call have had, and they go to the dermatologist regularly for those. They're very common, far common than the green fraction of the pie here in melanoma. When we look at the mortality, however, sorry about that, the green fraction becomes the largest proportion, largest contributor to mortality from skin cancers. Then a fair number is squamous cell, but then there is this purple fraction, which was not even visible. That's a rare cancer called Merkel cell, and probably more aggressive than melanoma. So between melanoma and Merkel cell, those are the kind of cancers that we as medical oncologists tend to see more of. And this is the reason why. Dr. Kim mentioned this, and Atta mentioned this too. Byrd has been chair of this committee which stages cancer. And as you can see, if you stage melanoma, this is localized melanoma, melanoma that had not traveled to the lymph nodes. So early stages 1 and the higher stages 2B, 2C. And this shows how do patients do over time. Just focus on the brown curve here. If you see stage 2C, there were 600 patients. And if you look at what happens to them over a 10-year period, only 75% are alive at 10 years. Now, that's a high number for a small lesion that was on the skin. 75% are alive, which is good, but 25% have passed away because the cancer, even though it had not spread to lymph nodes and the PET scan was clear, it eventually becoming metastatic. And so the point I'm trying to make is melanoma, the reason why it has a bad reputation is because it tends to spread early, even when it's very small on the skin. And if we see melanoma that has spread to the lymph nodes, the outcomes are even worse. So the principle that I keep in mind, and I know our surgeons and our pathologists are also keeping in mind, is that melanoma, even at earlier stages, we should view it as a systemic threat, not just a local or a regional threat, but we should be planning our treatment, keeping in mind that some of the cells may have escaped into the rest of the body and could pose a problem down the line. So if we have a systemic threat that we cannot see, the only way to address that will be to use systemic therapies. drug therapies that go throughout the body into the bloodstream. And even though we cannot see where the cancer cells are, those drugs are going to go there and address those cancer cells. When I started doing melanoma in 2005 or 2006, working with John Thompson, these were the only two drugs that were approved for melanoma. The old chemotherapy called dacarbazine, approved in 1975. And then there was this immunotherapy called interleukin-2. None of these had shown to improve survival of melanoma patients. But these were the only two options available. And we have had a lot of progress since then. On the left-hand side, you can see drugs that stimulate the immune system, ipilimumab, PD-1 drugs like pembrolizumab or nivolumab. You can use the combination of the two. There is a drug that we inject into the tumors called TVEC. And then on the chemotherapy side, this is not old chemotherapy. This is more targeted chemotherapy. We heard about the BRAF gene mutations. So you can actually inhibit that protein coming from the mutant genes. So we have the BRAF inhibitors. And then we have these other inhibitors called MEK inhibitors. And the combination seemed to work better than either of these drugs alone. Most recent approval for melanoma last year was now combining chemotherapy with immunotherapy. So these two drugs, vemurafenib plus cobimetinib, were combined with another immunotherapy called atezolizumab, and that's the most recent combination to be approved for stage 4 melanoma. So we have all this amazing progress, but how do we choose when a person is needing systemic treatment? How do we choose which one to use? So the first principle was we view it as a systemic disease. Second is, we want to match our treatment to what our goals are for each unique situation. So obviously, everybody who has cancer wants to be cured. And what does cure mean in this situation? What we are really trying to do is get complete remission. That means the tumors should shrink completely. We should not be able to see them. And then we want that effect to be long-term, not just for a few months or a couple of years. We want it to be sustained over, the rest of the life span. Now, cure is, you can say, yes, it's the ideal goal, but it may not be the realistic goal for many of our patients. So if we cannot cure, then we want to control the disease for as long as possible, so we prolong a person's lifespan. In some situations, cancer is causing symptoms by pressing on the nerves or in critical locations, pressing on the lungs, and people have cough. Those symptoms can only be relieved if we shrink the tumors and relieve that pressure. And also, last but not the least, most of our patients want to preserve their quality of life, or if they have symptoms, they want to improve their quality of life by getting rid of those symptoms. So one of the most important measures, and Dr. Hall is doing a lot of research on this, is how to avoid side effects, how to study the quality of life measures in patients. And an important part of it is toxicity considerations, how to avoid side effects. So once we have the goals for a particular situation, then we want to match our goals to the characteristics of the therapy we are going to use. For example, if we want to use a treatment to relieve symptoms, we want that treatment to shrink the tumors as fast as possible and as reliably as possible. If we are focusing on quality of life, we want to keep in mind the toxicity of the regimen that we are going to use. So these principles help us decide which treatment to pick for which situation. So I'm going to mostly focus on these two. How can we have a path towards cure, and what options actually give us the best chance of prolonging life? So the principle number 2, as to how I see things, is it is all about the immune system. So this is how I got interested in oncology. This gruff German professor whom I had the pleasure of interacting with in my residency, Peter Tischka, he's no longer with us, but he influenced my career in a big way. And he had this very interesting way of describing the cancer situation. Everything to him was about the battlefield. The immune cells were the soldiers, and the cancer cells were the enemy. And that has really shaped how I visualize the problem of cancer. And we know about these 3 E's of the cancer cycle. This is interaction with the immune system and the cancer cells. So if you see the cancer cells, and these are the immune cells. In the beginning, the cancer cells are trying to grow, but the immune cells have an upper hand and they are able to eliminate. But some of the cancer cells, the smarter ones, are able to survive that attack, and then they can get into an equilibrium phase where the immune cells are there, the cancer cells are there, they're coexisting with each other, but nobody has an upper hand and the cancer cells can be stable for a long time. So this is the equilibrium phase. Where most of our patients show up is when the cancer cells have somehow circumvented the immune mechanisms. They are able to escape the immune mechanisms, and then they are able to grow and form tumors that are clinically visible. So these phases are very important to how I conceptualize where a patient might be. And our obvious goal is to take them towards elimination. And sometimes we settle with equilibrium, but we try to avoid immune escape through creative ways. So immune checkpoint inhibitors are one way of accomplishing that. So what are immune checkpoint inhibitors? So this is a vicious looking cancer cell, and these are immune cells. Cancer cells are very smart. Even though these immune cells can recognize the cancer cells through cancer-specific antigens, the cancer cells press on these brakes on the immune cells, and by pushing on these brakes, they render the immune cells exhausted. So as you can see here, what we are doing with immune checkpoint inhibitors is block this interaction. So the cancer cells cannot push on the brakes anymore, and hopefully the immune cells will be re-energized, and then they can kill the cancer cells. So indeed, that strategy worked for some of our patients. With the earliest immune checkpoint inhibitor that was successful was ipilimumab, which is blocking a brake called CTLA-4. So what we saw early on is when patients had tumors, and in this case, very large, troublesome tumors on the back, when they got this drug, the tumors kept growing. And at this time, it looked like, oh, this drug is not working. But then if you wait a little bit longer, the tumors start shrinking, suggesting that this apparent increase in the size of the tumors was actually inflammation coming from the drug, the good kind of growth, so to speak, what we call pseudoprogression. And since the immune cells were able to overcome the tumor cells here, the tumors start shrinking. And you can see that this response became very durable. 2 years later, there was nothing visible on the skin. So this did not happen very frequently with ipilimumab. The chances of it happening were close to 25% or so. 75% of the times it did not work. But the beautiful thing was when it worked, those patients ended up doing really well. So if we look at how many patients were alive at 3 years, it was around 20% or so. But if you follow it up to 10 years, the vast majority of those patients who had a successful immune response with immunotherapy early on, that immune response kept them going for many, many years. So again, suggesting that the power of the immune system is immense. If we are able to successfully stimulate the immune system, the responses can be very long-term. Now, this comes at a cost. I'm not going to go too much into the toxicity side, but just want to say we are messing with the immune system in a big way. It can create lots of complications, including sometimes in rare situations, even life-threatening complications. Sometimes it can cause permanent side effects that can affect quality of life. For example, some people can have type 1 diabetes or neuropathy. So we need to carefully monitor our patients. If there are new symptoms, new side effects, we want to be managing those very aggressively. And with that aggressive management, we can control most of the side effects. So for immunotherapy now, since the old days from ipilimumab, we have actually come a long way. We have better drugs now. We have the anti-PD-1 agents, which are pressing on a different brake. These can be used either as monotherapy or in combination with ipilimumab. And there are two drugs that you may have heard of. One is pembrolizumab or Keytruda. Another one is nivolumab or Opdivo. So if you look at comparing the two drugs, if you look at the pembrolizumab, for example, comparison to ipilimumab, this is the chance of significant shrinkage. the PD-1 drugs work more effectively than ipilimumab. But if you look at the side effect rate, they are actually less toxic. So they are a win-win on both fronts. They work better and with lower toxicity. Similar results with nivolumab, better response rates, lower toxicity. So because of this, we don't use ipilimumab upfront anymore. We use PD-1 based drugs, either PD-1 alone or in combination with ipilimumab. So if we combine the two, we get even more chance of shrinking the tumors. However, it comes at the cost of greater toxicity. So should we be using PD-1 or should we be using PD-1 plus IPI? That answer is not absolutely clear, but there is suggestion that if people get more aggressive immunotherapy upfront, they actually end up doing better in the longer term. So I think our priority, the way I'm thinking about it in the clinic again, is that if we want the best shot at long-term survivorship, it probably makes sense to do the combination, unless there is a strong reason not to do it. It could be patient preference or a very high risk of toxicity, in which case we could use monotherapy first and then move to combination as needed. So these are my conclusions on immunotherapy. It can lead to durable responses, long-term responses, and long-term survivorship in a subset of melanoma patients. PD-1 monotherapy with pembro or nivo is superior to IPI, better efficacy, lesser toxicity. And if we use the combination, it has higher chance of tumor shrinkage, but it also comes at a greater risk of toxicity. And we need to see good survival advantage, although it seems to be emerging. Now, lastly, one size doesn't fit all. Clinical decisions have to be individualized based on everybody's own unique goals of care and risk tolerance. So this brings me to the principle number 3. Again, immunotherapy works in such a good way for some of our patients. So the way I'm thinking is, if I want my patients to do the best in the long term, I'm planning their treatment thinking, how can I stimulate their immune system? If my first attempt doesn't work, then I'll try something else. So the principle is, I'm thinking immunotherapy, 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 unless I'm forced to use something else. So there are fortunately many different ways of stimulating the immune system. So this is an elderly woman who loved to dance, and she had a major surgery. Dr. Kim showed you some pictures suggesting how difficult it can be in some locations to do closure of the skin. And so we end up grafting, and you can see the big hole, big scar over there. But then despite that aggressive surgery, this patient had multiple tumors that grew in the vicinity of that primary area. So what we ended up using, rather than doing much more extensive surgery or radiation, which we knew would not have been curative, we ended up injecting immunotherapy drugs into one of these tumors. And that was minimally toxic. And you can see it worked not just in that one tumor, but in other tumors as well. They all disappeared, and she went into complete remission with minimal side effects. I want to put in a plug for Dr. Moshiri here. When he wears his dermatologist hat, he's actually leading our program of injecting this herpes virus called TVEC. And we also have several other trials injecting novel immunotherapy drugs into the tumors, hoping that we will not only create local responses, but more widespread systemic responses. So again, a creative way of thinking about how to stimulate the immune system from a systemic standpoint. Then there are a lot of interest in T-cell therapies. We can remove a tumor by surgery, isolate the immune cells that are in the tumors. Those are called tumor infiltrating lymphocytes. We can expand those to an army of billion cells in the lab and then infuse those cells back into a patient's blood. There is a lot of interest in CAR T-cell therapy, where we can actually modify those immune cells genetically and make them super immune cells and give it back to the patients. So these trials are up and running. Dr. Lee is leading one of the TIL trials at our center. Dr. Josh Veach, another one of our medical oncologists, is following yet another very interesting approach, where we analyze the tumor tissue very extensively, look at the DNA, look at the RNA, find out what mutations are in the tumor tissue which are not present in the normal tissue. Those are cancer-specific mutations. And based on those mutations, we can create vaccines that are specific for the cancer. These are the so-called neoantigen vaccines. And then these vaccines can be used to stimulate a new immune response against those cancer antigens. So these are in some ways, a perfect example of personalized therapy. Each vaccine is very unique for that patient's tumor, which is exactly what we want to do. Instead of using one drug for everybody, we are rapidly moving towards therapies which are personalized to each patient's unique situation. There are other creative ways coming out. This is actually kind of hot off the press here. This drug by Bristol Myers Squibb is another immune checkpoint inhibitor targeting a novel molecule called LAG3. And the company just released a news that their frontline trial appears to be positive. So instead of using PD-1 alone, they combined the PD-1 with this drug, and apparently the combination is better than PD-1, but not as toxic as Ipi/Nivo. So that may be an example of improving the efficacy without having that substantial additional toxicity. So how does this drug work? We know that our immune cells can be exhausted by the cancer, but there is different levels of exhaustion. Some immune cells may be somewhat exhausted, but they are still, able to recover. And then there's some cells that could be more terminally exhausted. So we can rescue a proportion of those with anti-PD-1, but to rescue these terminally exhausted cells, we may need to use other drugs like LAG3. But if we use the combination, we have an even stronger army to fight cancer. The principle number 4 that I use is I'm always thinking about immunotherapy, but I also realize that immunotherapy doesn't work all the time. So this is an example from Hindu mythology. This demon had multiple heads, and the demon abducted Rama's wife, and so they went into the battle. The trouble was every time Rama tried to kill this demon by beheading, he had 10 heads. Every time you behead one, another head would grow back. So this is exactly what cancer does. We take one hit at it, we might be successful temporarily, but then the cancer comes back. So the only way to kill the demon was to find an essential vulnerability in the demon, and it turned out that his umbilicus was the only soft spot. And when Rama hit an arrow towards his umbilicus, that's when the demon died. And in some ways, that's what we need to do for cancer too. We need to find that primary vulnerability. And once we identify that, we may be able to overcome this problem. But in the meantime, we need to keep taking multiple shots. All we need is one good hit. If we are successful in getting that, then we can make a big difference for that patient situation. And I just want to leave by saying that while we are really passionate about immunotherapy, because we think that's really the key to overcoming this challenge of cancer, it does not work all the time. If you look at these drugs, Pembro and Ipilimumab, these tumors are growing. There's a substantial proportion of patients whose tumors do not respond at all. So we have other options. We have the BRAF/MEK inhibitors that can work very reliably and rapidly for some patients who have the BRAF mutation. Dr. Kim, Dr. Byrd are doing surgery, and we use them sometimes for metastatic situations too, because we want to reduce the bulk of the tumor burden. We can use surgery to harvest stills, remove resistant tumor clones. Similarly, we can use radiation to palliate symptoms. And there are also added advantages. If we use radiation, it can theoretically increase the visibility of the cancer cells to the immune system. So other therapies are not redundant. They can still synergize with what we are trying to do, but we have to think of it as a systemic problem. And this is my last slide. We are making progress. So if you look at melanoma incidence and mortality in the US, just 3 years back, there were 91,000 new cases of melanoma, and almost 10% of those cases eventually led to death. So 9,000 deaths. The numbers in 2020, there were more melanoma cases, but you look at the number of deaths, from 9,000, it has gone down to 6,800. Why is this happening? This is happening because of the success of systemic therapy. We are using these systemic therapies early on in patients' course. Dr. Kim mentioned about adjuvant therapies, neoadjuvant therapies, and I think that's how we need to keep making progress, and that's where I'll stop. Thank you so much for your attention.
Wonderful, wonderful talk. Thank you so much, Shailendra. That was very inspiring, very exciting to see what's on the horizon. You did get some questions in the chat. I know that we've stretched beyond what we originally asked people to stay for, so I'm going to let you tackle some of those in the chat. I'm going to finish my talk, and then we'll have a few brief remarks to wrap up, and then let everyone enjoy their Saturday afternoon. But that was really a great talk. Thank you. So I'm going to share my screen again. Hopefully this works. Okay. So this is, all right, so this is where we were. I could not show this image before. So to just go back one slide, Judy is a 48-year-old female who recently had been diagnosed with stage 3A melanoma. So these many themes in these talks that are resonating through Dr. Kim's talk, Dr. Bhatia's talk. You know, how do we know where the melanoma is going to cause a future problem? How do we act and intervene on those patients, but not intervene on the people who won't have a future problem after surgery? So she had the pathologic features of a stage 3A melanoma, and she had additional workup that we couldn't detect any cancer for Judy after her surgery, to the best that we could tell. And this is a very common patient that we see in our clinic. And we know from studies like those Dr. Kim and Dr. Bhatia mentioned that many patients won't have their melanoma come back, but some will in this very same situation. And so what we're left with is a decision about whether to treat a lot of people, knowing that only a few of them are the ones that actually were going to have the melanoma come back, and exposing everybody to the side effects of treatment, or potentially not treating someone, but having them be the person who might have had it come back. And it's a very challenging situation in clinic. And it's one place that I think this circulating tumor DNA could be helpful. So when I see patients like Judy in my clinic, and I've seen a large number of them in the time I've been at Seattle Cancer Care Alliance, they all look similar. They've had surgery, they're stage 3A patient, and none of them have detectable melanoma that I can see. But over a 5-year time point, about 20 or so patients in that situation will have a recurrence. And if we could somehow, a perfect test would allow us to say at the time after surgery, who are the 20 people in blue on this schema who are going to have a recurrence? And boy, we should do more treatment for those patients because they're destined to have their melanoma come back. And the 80 people who aren't going to have their melanoma come back, maybe we should just do something less intensive and expose them to less side effects because they're going to do very well. We don't have a perfect test, and I don't think ctDNA is going to be perfect, but what I do think it could eventually take us is to somewhere closer to this, something like this, where perhaps of those 20 patients, maybe 10 patients might have ctDNA positive after their surgery. And if, you know, in melanoma, if melanoma follows the way other cancers have gone, like colon cancer, those patients may be at a very high risk of recurrence, and they could consider doing more aggressive treatments after surgery. They may be enriched in those 20 patients overall who are likely to have recurrence. And so I think that the ctDNA test may move us more towards the idea of personalizing treatment after surgery for our patients. This is an example of what such a DNA test might look like. This is a patient who had multiple surgeries for their melanoma. They had, this is on the scan here, there are a couple dark spots in the left side of their neck, in their parotid gland, and in their neck lymph node. And at the time of their surgery, they had detectable ctDNA. This number is not 0. If there's no tumor left in the body, the ctDNA should be 0. And so they had surgery initially. Their ctDNA didn't go down. They ended up having a second surgery. It was still elevated. And then they started on immunotherapy, and their ctDNA disappeared. And we know, we believe that probably means the immune system was able to mop up any residual microscopic cancer spots that were left. But we think that this trend, this measuring the trend of ctDNA over time could be quite helpful for people that are getting treatment after surgery. And this is an example of how this might look. Briefly, the other scenario is the patients with metastatic disease, like those that Dr. Bhatia talked about. Currently, when we start a treatment, we wait a while to see if it's working. He showed that picture where it looked like the tumors were actually growing, but then later on they actually shrunk. And so we have to wait a while to tell, just from looking at scans and looking at the skin, if our immune system, if our immunotherapies are working well. Sometimes that's 12 weeks or 16 weeks or longer. Usually we do this with CT scans, and we're really looking usually for things shrinking as a good indicator that we're on the right track. But as Dr. Bhatia mentioned, that can be complicated sometimes. And we know that in melanoma and other cancers, ctDNA levels falling correlates pretty well with future cancer shrinkage, and that it can actually happen sooner. And so it may be a way for us to identify how well our treatments are working sooner, so that if we're not on the right track, we may be able to switch treatments to something that's more effective, instead of waiting 12 to 16 weeks to find that out later on. There's additional evidence that if you have less ctDNA when you're diagnosed with metastatic melanoma, immunotherapy might work better for you. That if your ctDNA levels decrease while you're on immunotherapy, that those patients live longer, patients with metastatic disease. And that looking at ctDNA status with about a month after starting on treatment with like a BRAF or a MEK inhibitor, like Dr. Bhatia talked about in his talk, that looking at if the ctDNA is detectable or not can tell you a lot about how likely and how long that treatment is going to work. So there's a lot to learn here, but I think it's very exciting in a way that may allow us to give more personalized care for our patients and more precision care. So as an example, if John is a patient with metastatic melanoma who has a BRAF mutation and is started on immunotherapy, we may check his ctDNA level at some time in the future as he starts treatment and it's after 6 weeks of immunotherapy. And if his ctDNA level was rising very quickly, that may make us concerned about whether or not this immunotherapy was working well for him. And it's possible that at some point in the future, we would use this information to make a decision to actually switch his treatment to a BRAF and MEK inhibitor, which we know work very reliably for some patients and work very quickly, rather than waiting an additional 2 to 3 months until the scans result and show cancer growth. So this is a way in which this might be something that we're doing a few years from now. So final thoughts, and I appreciate you hanging with me through the 2 parts of my talk. ctDNA is an emerging technology. It's not ready for routine use yet, but it definitely could help us in the future personalize and tailor our therapy. It's currently being used in the care of patients with colon cancer and may be used in the routine care of melanoma patients very soon. If you detect ctDNA in a situation after surgery, it may identify patients at a higher risk of treatment. That seems to be true, although in melanoma, we're still building the data that will allow us to say that conclusively. And monitoring the trend in the level may be useful for patients with metastatic melanoma. This is an ongoing area of research, and we're very excited to see how this pans out, but I think this is something that could be coming in the future. So that's the conclusion of my talk. I'm going to stop my screen share. Great. And I will answer some questions in the chat for a bit, but I know we've gone a little over our scheduled time. I want to be respectful of everyone's time. I want to just end by thanking everyone who's participated in today's session. This is really why we run this event. The Melanoma Research Foundation was tremendously supportive of this event, and we really enjoy partnering with them, and we really look forward to doing that in the future. So thank you to the MRF. To Ritu for organizing all of the speakers and the Zoom, a really big thank you. To my co-chair, Dr. Byrd, to all of our speakers who generously donated their time on a Saturday to participate in this. We really appreciate it. And most of all, to our attendees and caregivers and everyone who joined. We had over 100 people on the call for most of the morning. The enthusiasm was high. The questions were coming fast and furious. Even though we were doing this virtually and not as we preferred in person, I think it was a great event. And I really thank you all. You're really why we do this. And it's really exciting to see everyone engaging. I would like you to fill out, if you will, fill out the survey that we are going to send out about our event. We look at the feedback very closely for this event, and we'll make changes based upon feedback that we get. So if there was something you really liked about the program this year, we'd love to hear about it. If there were things that you think would be better or you'd like to change, we will look at it and consider implementing it next year. So you'll receive a post-conference survey. It's been posted in the chat, and so please fill that out. We really do value the input because we really want to make this event as useful as possible for you. David, any?
Evan, just a quick comment, just so everybody in this call knows, Evan and Ritu organized this whole thing. I'm listed as co-chair. This was their work. Fantastic symposium, just fantastic. I think you're seeing it from the people, the claps, you're seeing it in the people in the chat. Great job. But I think we all realize we want your voices as our participants. Next year, I cannot wait to have you engage again and see you in person. Fantastic day. But I just want to mention that I thought it was outstanding. And Vita, I don't know how you did all this, but you pulled this off flawlessly. Dr. Hall had his own gizmo with his computer. Everything else was absolutely perfect. Thank you to everybody, and especially the speakers.
That's a great way to close it. So thank you all again very much. Please fill out the surveys, and thank you all for a wonderful day. And we look forward to doing this in person in 2022.
And MRF, I see Amy just pop on. Thank you, MRF, as well, as always.
Thanks, everyone.